सेकंड्स पे लगा हुआ है ये टाइमर। हमको लगता है बंद ही रखते हैं, बोलने की ज़रूरत तो नहीं है मेरे ख्याल से। तुम लोग सबको विजिबल है ना? ओके मैं बोल, विच ओरल एंटी डायबिटिक ड्रग इज द रिकमेंडेड फर्स्ट लाइन थेरेपी इन टाइप 2 डायबिटीज़?
क्वेश्चन 2 आया था।
हाँ आया था। विच पैनक्रियाटिक सेल सेक्रीट इंसुलिन? Which acute metabolic emergency is more common in type 1 diabetes? Name the microvascular complications of diabetes that is the leading cause of preventable blindness. Which cranial nerve is most commonly involved in diabetic mononeurotherapy? Neuropathy. कम से कम 20 मिनट लगेगा लास्ट राउंड में। What is the HbA1c cutoff used for diagnosing diabetes? Which oral anti-diabetic drug should usually be withheld before administration of iodinated contrast? Which diabetic complication is detected by measuring urine albumin to creatinine ratio? Which glucose transporter is insulin dependent in skeletal muscle? What is the earliest detectable abnormality in diabetic nephropathy? Which landmark trial established the cardiovascular benefit of empagliflozin? Which scoring system is commonly used to assess the probability of diabetic ketoacidosis resolution? According to ADA, what is the preferred first injectable therapy in most patients with type 2 diabetes before insulin? Which incretin hormone is rapidly degraded by DPP4? Which gene mutation is most commonly associated with MODY3? Which glucose transporter is responsible for renal glucose reabsorption and is targeted by SGLT2 inhibitors? What is the name of the dual GIP and GLP-1 receptor agonist approved for type 2 diabetes? Which trial demonstrated renal protection with finerenone in patients with diabetic kidney disease? ये end कर देते हैं अपन। ये end कर दिया है कल मैं कैसे 20। अभी अगर कोई टाई होगा तो हम टाई देकर क्वेश्चन देंगे, ठीक है, जिसके बीच टाई होगा। हाँ अच्छा ठीक है, मैं फटाफट दिखा देती हूँ एकदम। ये हटाया हुआ है ना सब। So which hormone is absolutely deficient in type 1 diabetes mellitus? Question 2. Name the investigation considered the gold standard for assessing long-term glycemic control. Third, which oral anti-diabetic drug is the recommended first-line therapy in type 2 diabetes? Which pancreatic cells secrete insulin? Which acute metabolic emergency is more common in type 1 diabetes? Name the microvascular complication of diabetes that is the leading cause of preventable blindness. Which cranial nerve is most commonly involved in diabetic mononeuropathy? What is the HbA1c cutoff used for diagnosing diabetes? Which oral anti-diabetic drug should usually be withheld before administration of iodinated contrast? Which diabetic complication is detected by measuring urine albumin to creatinine ratio? Which glucose transporter is insulin dependent in skeletal muscle? What is the earliest detectable abnormality in diabetic nephropathy? Which landmark trial established the cardiovascular benefit of empagliflozin? Which scoring system is commonly used to assess the probability of diabetic ketoacidosis resolution? According to ADA, what is the preferred first injectable therapy in most patients with type 2 diabetes before insulin? Which incretin hormone is rapidly degraded by DPP4? Which gene mutation is most commonly associated with MODY3? Which glucose transporter is responsible for renal glucose reabsorption and is targeted by SGLT2 inhibitors? What is the name of the dual GIP and GLP-1 receptor agonist approved for type 2 diabetes? Which trial demonstrated renal protection with finerenone in patients with diabetic kidney disease? कलेक्ट कर लीजिए। ABCD होता जाएगा। एक बार खाली पास होने का तो ऑप्शन मिलेगा, अगर ये पास कर देता तभी तुमको मिलता। सारे राउंड्स में सेम ही रूल है। अब अगर अब ये एक इसका एलिमिनेट हो गया, अब उसके बाद तुम बोलोगे फाइनली तो आ जाएगा ना आंसर, वैसे नहीं होगा। एक किसी ने रॉन्ग आंसर किया, वहाँ पे वो क्वेश्चन ब्लॉक हो जाएगा। अगर टीम 1 भी रॉन्ग आंसर दे देगा तो ब्लॉक हो जाएगा, वो पास नहीं होगा। एक ही बार पास होगा, तब तक पास हो सकता है जब तक उसका किसी ने आंसर नहीं दिया। पास अगर ये बोलता तभी पास होता, इसने पास नहीं किया, इसने आंसर दिया है। ठीक है, तो -5। ठीक है, टीम 2 का क्वेश्चन है, इसका आंसर ये है। टीम 2 का क्वेश्चन, +10। टीम 3, under the revised staging system for type 1 diabetes, stage 1 disease is defined by
option C, 2 or more islet autoantibodies with antibodies.
correct. Team 4, teplizumab, an FDA approved Fc receptor non-binding anti-CD3 monoclonal antibody used to delay progression of high risk stage 2 type 1 diabetes, acts principally by
Option B.
correct. Team 5, in type 2 diabetes, insulin resistance in skeletal muscle is now understood to be predominantly due to ठीक है, करेक्ट, +10। सो राउंड 1 खत्म हुआ हमारा। राउंड 2, so this is a case, a 68-year-old man with long-standing type 2 diabetes is brought in obtunded state. Plasma glucose is 890, arterial pH is 7.32, bicarb is 19 and urine ketones are trace positive. Serum osmolarity is markedly elevated. What is the most likely diagnosis? टीम 1 का है। ठीक है, +10। Team 2, a patient on an SGLT2 inhibitor undergoes elective surgery. Post-operatively, she develops nausea, vomiting, abdominal pain and metabolic acidosis, but her plasma glucose is only 180 mg per dl. What is this deceptive presentation called?
Glycemic delay.
+10. Team 3, a patient with new DKA has an initial serum potassium of 5.8. Insulin infusion is about to be started. What is the correct approach to potassium management?
Option A, remove all potassium initially and replace it with plasma.
+10. Team 4, on CGM targets level 2 or clinically significant hypoglycemia is generally defined as a glucose below 100, 70, 54, 40.
C, 54 and
ठीक है। Team 5, during a hypoglycemic crash, which counter-regulatory hormone is released first to defend the plasma glucose?
C, glucagon.
+10. Round 3. So, islet autoantibodies are typically present in type 1 diabetes but not in classic type 2 diabetes. Team 1. True or false? ठीक है, +10. A 24-year-old woman presents with polyuria, weight loss, fasting glucose of 280, BMI of 20, and strongly positive GAD antibodies. The most likely diagnosis is plus. Team 3, current recommendations advise screening for gestational diabetes between which weeks of pregnancy? Diabetes diagnosed in first trimester of pregnancy is classified as gestational diabetes mellitus. True or false? Team 4. -5. ये मुझे लग रहा था गलत क्वेश्चन आ गया सीक्वेंस में, बट ये ट्रू हो फॉल्स होगा ना वो, ये से ट्रू बोलना. Team 5. Most women with gestational diabetes revert to normal glucose tolerance postpartum, but what proportion go on to develop type 2 diabetes within the next 10 to 20 years? ठीक है, हाँ वो हम दे देते, अगर उसका क्वेश्चन सिमिलर नहीं आया रहता तब उसमें गलत हो गया ना, जस्ट आया था. थोड़ा सा तो बीच में फन रहना चाहिए क्वेश्चन. Team 3, people with diabetes must eliminate all sugar and sweets from their diet permanently. Fact or myth? Myth. Last 10. Team 4, only people who are overweight or obese develop type 2 diabetes. Fact or myth? Team 5, needing to start insulin means a patient has personally failed to manage their type 2 diabetes well enough. Fact or myth? अभी थोड़ा डिफिकल्ट है. टीम 1 का फाइनल होता है. जो मैंने डिसीजन, इसमें इस क्वेश्चन को कुछ नहीं करते, ठीक है, सब 0-0 रहेगा इस पे. राउंड 10 लास्ट है, 3 मार्क्स ये उसके लिए क्या करना, आधा सही बोल रहा था.
आई एम ऑडिबल ना? हाँ, तो बताओ।
ऑलवेज रेडियली प्रेफर करना होता है बिकॉज का कोलेट्रल होता है, ठीक है, एंड सुपरफिशियल क्षेत्र इज इजी टू टेक दिस सैंपल फ्रॉम रेडियल रेडियल देन फिमोरल एंड देन लास्ट डॉर्सल यही की पहले फिमोरल और उससे पहले करने से पहले एलन स्ट्रेस एवरीवन नोस एलन स्ट्रेस। सो पॉल मरीनो बुक है ICU की गॉडफादर ऑफ पॉल मरीनो। Without knowledge of basic knowledge of ABG and you are working in any critical care settings is like you are wasting your time here, है ना? Without ABG के knowledge के बिना basic knowledge के बिना can't run any critical care setup. Okay, have at least basic the learning objective why do we need an ABG and we'll check the internal consistency कैसे check करते हैं step by step and finally we'll whether we will be able to interpret an AG or not. This will be the learning objective. So why do we order an APG? हम क्यों कराते हैं APG? Gas analysis क्या PO CaCO और very good acid या alkalosis है और electrolytes के लिए very good और pH के लिए okay. First so to stabilize the diagnosis and then we will guide the treatment plan है ना। वेंटिलेटर सेटिंग्स के लिए भी हो सकता है कि ICU में you are working तो whether your ventilator settings are good or not and उसके बाद चेक करने के लिए कि पेशेंट इम्प्रूव हुआ कि नहीं तो चेक करना। कोई बता सकता है कि कैसा ABG है? मैं सिर्फ तीन ही ऑप्शन देता, चौथा मुझे पता नहीं है। पहला ऑप्शन है नॉर्मल, दूसरा एबनॉर्मल, तीसरा पता नहीं कौन सा है? इधर तो लोग क्या कह रहे हैं नॉर्मल, इधर से नॉर्मल है तो मैं कहते टॉप पर ये तो बोल रहे हैं सही बोल रहे हैं, इधर से एक्सपीरियंस लगे बताइए नॉर्मल है, ठीक है। मैं लेकिन बोलता हूँ कि ये जो ABG है ये इस पेशेंट का है, इंट्यूबेटेड पेशेंट है, वेंटिलेटर पे है, 100% FIU। नाउ अब ये ABG कैसा है? यही ABG कैसा हो गया? नॉर्मल, अब स्टिल नॉर्मल, एबनॉर्मल स्टिल नॉर्मल, वेंटिलेटर पे है, FIO 200 पे है, इसलिए बता दो इलेक्ट्रोलाइट्स मान लो नॉर्मल है, विद इन नॉर्मल रेंज में। ABG इज नॉट फॉर द इलेक्ट्रोलाइट्स। क्या लग रहा है नॉर्मल अभी 100% FiO2 है पेशेंट, 100% FiO2 लिए PO2 is 80 which is very less ना। हाइपोक्सिमिया में सिवियर हाइपोक्सिमिया में पेशेंट। तो कहने का मतलब ये इस स्लाइड का कि नेवर इंटरप्रेट एन ABG विदाउट आस्किंग द FiO2। जब भी हम ABG सैंपल लेकर भेजते हैं एनालिसिस के लिए भी ऑलवेज डॉक्यूमेंट कि ये हमने इतने FiO2 पे निकाला है और ये इस टाइम इतना टेम्परेचर था पेशेंट का। तो दीज आर वेरी इंपॉर्टेंट टू कैलकुलेट कि मशीन वो एक्यूरेटली कैलकुलेट कर पाए ना। नेचुरली तुम भेज दोगे वो रूम एयर पे लगा देगा, पेशेंट 100% FiO2 पे या 60% पे है तो सारी रीडिंग्स एक्स्ट्रापोलेट करके निकालता जाता था तो वोंट कम करेक्ट है ना। और जब भी कोई ABG आता है इंटरप्रेट करने के लिए और गोइंग टू मैनेज द पेशेंट राउंड्स पे करके देखा एंड यू सॉ स्टाफ ने दिखाया, जब दिखाया कि सर ये ABG है तो नेवर इंटरप्रेट ABG विदाउट आस्किंग कि इसका कितने FiO2 होता है ना। दैट्स द वेरी इंपॉर्टेंट। और ABG मशीन हमें सिर्फ तीन ही पैरामीटर्स कैलकुलेट करता है, pH, PCO2 और PO2। pH, PaCO2 और PO2 यही तीन चीजें निकालता है बस। बाकी जो भी वैल्यूज आती है बाइकार्बोनेट, लैक्टेट, PO2, SO2 ना, ये सब एक्स्ट्रापोलेट करके निकालते हैं इन तीन वैल्यूज पर, ठीक है। तो बाकी वैल्यूज पे हम उतना रिलाई नहीं करते, पर जैसे इलेक्ट्रोलाइट्स है वो सब एक्स्ट्रापोलेटेड ही होता है। तो नेवर रिलाई ऑन ABG इलेक्ट्रोलाइट है ना, ऑलवेज आस्क फॉर द सीरम। काफी बार होता है और ये से बोल रहा है। There are various approaches, Boston approach, Robert Miller approach, Stewart approach, MCQ में आ सकता है, ठीक है। Most commonly हम Boston approach से use करते हैं। Robert Miller's approach is for base access and the last Stewart based on the strong ion dissociation। उस techniques पे base होता है, ठीक है। मशीन ने निकाले कि निकाले, दैट इज कॉल्ड द इंटरनल कंसिस्टेंसी, ठीक है। सो उसके लिए दिस इज फॉर्मूला, द हेंडरसन-हाइजेनबर्ग इक्वेशन, दिस H plus is equal to 24 into PaCO2 एंड बाइकार्बोनेट। इसको हम थोड़ा सा मॉडिफाई करके हम ऐसे भी लिख सकते हैं, H plus into बाइकार्बोनेट डिवाइडेड बाय PaCO2 is equal to the 24, 24 होना चाहिए। H plus कैसे निकालेंगे? The H plus वो तो बहुत लेंथी कैलकुलेशन हो गया, उससे निकालते तो वैसे ही है, बट तो शॉर्टकट के लिए तो पीएच की जो डेसिमल के बाद जो 2 डिजिट्स है उसको हम 80 से माइनस कर देंगे, ठीक है। सो लाइक इन दिस 7.20 है तो h plus becomes 80 minus 20, so it's 60, समझ में आया? h plus simply we can calculate, बट ये फॉर्मूला तभी तक वैलिड है जब तक pH is between 7.2 to 7.5, जैसे 7 हो जाएगा 7.1 या 6.9 तो इट वोंट वैलिड, और 80 से नहीं मिलेगा, तो इसके लिए अलग वैल्यू जाएगी। 7.1 में जाओगे तो 90 हो जाएगी, 7 पे जाओगे तो 100 हो जाएगा, तो 7.2 to 7.5 के बीच में अगर pH है 80 minus 20 you will get the H plus and 60, ओके। सो इसमें हम चेक करते हैं इसका इंटरनल कंसिस्टेंसी क्या है। 54-year-old male known case of diabetes since last 10 years presented to the ED with respiratory distress and on 2 liters per minute IBD कराया, तो इसमें H plus क्या है आपका? इसका H plus कितना हुआ? 60 into बाइकार्बोनेट कितना हुआ? 60 into 50 divided by 30 कितना आया? है? ठीक है 900, ठीक है 30, 60 into 30 divided by 15 और 60 into 50 divided by 30, sorry 30 आया ना, ओके। सो इट शुड बट 24 आना चाहिए था, so it's not valid, this report is not valid, okay। That is why this is how we calculate the ABG, internal consistency। So after consistency check करने के बाद then we'll go to interpret the ABG कि उसके कैसा है। First step is always check for कि patient acidemia में या alkalemia में। Acidemia is the acidosis in the blood, blood के अंदर pH is lower side, acidemia, alkalemia in blood, we are talking about blood। So the normal pH is between 7.35 to 7.45, 7.45 के जैसे ऊपर जाएंगे तो alkalosis, and less than 7.35 is the acidosis। The central value is 7.40, तो हम अगर सपोज करो इस 7.4 के लेफ्ट में जाएंगे तो एसिडोसिस होगा, 7.40 के राइट साइड में जाएंगे तो एल्कलोसिस होगा, ठीक है। एंड द PaCO2 is 35 to 45, central value is 40, एंड सेम बाइकार्बोनेट 24 to 26, 24 से नीचे 22 से नीचे जाएंगे तो एसिडोसिस होता है, समझ में आ रहा है? फाइनली स्टूडेंट्स बाइकार्बोनेट अगर हम नीचे की तरफ जाएंगे 24 से नीचे की तरफ जाएंगे तो एसिडोसिस होगा, ठीक है, 24 से ऊपर जाएंगे तो एल्कलोसिस होता है, ओके। सो हम कैलकुलेट करने के लिए pH का सेंट्रल वैल्यू 7.4 लेंगे और PaCO2 का 40 लेंगे एंड देन बाइकार्बोनेट का विल कैलकुलेट विद 24, ओके। कोई डाउट? 24 इज द सेंट्रल वैल्यू फॉर द बाइकार्बोनेट, ऐसे इस PaCO2 के लिए 40 होता है, ठीक है। सो दिस इज बेसिक्स। So we will go to the, after looking for the patient is in acidosis or alkalosis, then we will calculate कि which is the primary pathology, either metabolic or respiratory। अगर बाइकार्बोनेट में कोई चेंज होगा to maintain the pH तो metabolic होता है, अगर respiratory की वजह से होगा तो that is the PaCO2 की वजह से होगा तो respiratory cause होगा, ठीक है, ठीक है। बाइकार्बोनेट की वजह से होगा तो metabolic disorder होगा, PaCO2 की वजह से होगा तो respiratory disorder होगा। And this is the Rome criteria। अगर the relationship between pH and PaCO2, अगर pH बढ़ रहा है and PaCO2 pH बढ़ रहा है मतलब pH on the right side alkalosis की साइड जा रहा है, मतलब 7.4 के ऊपर जा रहा है and PaCO2 is lower side में जा रहा है, मतलब अपोजिट डायरेक्शन में चल रहे हैं, तो the primary pathology will be the respiratory, ठीक है। respiratory is opposite and metabolic के साथ साथ pH मूव करता है, मतलब pH डाउन होगा तो बाइकार्बोनेट भी डाउन होगा तो मेटाबॉलिक एसिडोसिस होगा। अगर 7.6 pH या बाइकार्बोनेट 35 है तो दोनों एक सेम डायरेक्शन में आ, दोनों बढ़ रहे हैं, इंक्रीजिंग साइड में है, तो मेटाबॉलिक एल्कलोसिस होगा। अंडरस्टूड ये बेसिक चीज यहाँ पे बच्चे पीछे समझ में आ गया, इसमें कोई डाउट नहीं होना चाहिए, दैट इज द वेरी बेसिक, इसके बिना हम आगे बढ़ ही नहीं सकते। अगर इसमें कोई भी डाउट है तो वी कैन नॉट मूव अहेड। लास्ट में समझ में आ रहा है, ठीक है। एंड इफ रेस्पिरेटरी प्रॉब्लम, अगर रेस्पिरेटरी प्रॉब्लम होता, जब भी कोई एसिडोसिस होता है पीएच में, बॉडी में पीएच चेंज होगा, अगर मेटाबॉलिक कॉज की वजह से होगा तो रेस्पिरेटरी कंपनसेशन बहुत जल्दी होता है, बहुत जल्दी पेशेंट हाइपर वेंटिलेट करने लग जाएगा, ठीक है, या हाइपो वेंटिलेट करने लग जाएगा टू मेंटेन द पीएच, ठीक है। तो बहुत तुरंत होता है मेटाबॉलिक कारण की वजह से रेस्पिरेटरी कॉजेस, ठीक है। इसलिए मेटाबॉलिक कैन नॉट बी एक्यूट और क्रॉनिक, बट रेस्पिरेटरी, देखो रेस्पिरेटरी जो होता है, अगर रेस्पिरेटरी की वजह से प्रॉब्लम है तो किडनी विल टेक टाइम टू बफर द पीएच, ठीक है, इट कैन टेक्स days to week, so it can be divided into acute and chronic। जल्दी से अगर कंपनसेट हो तो टाइम लेके होगा, तो रेस्पिरेटरी अगर कोई भी डिसऑर्डर होगा कैन बी एक्यूट एंड क्रॉनिक, बट मेटाबॉलिक में ऐसा कुछ नहीं है, ठीक है, क्योंकि मेटाबॉलिक में अगर कोई प्रॉब्लम हुआ तो रेस्पिरेटरी तुरंत कंपनसेट करने लग जाएगा। सो उसके बाद हम कोई रेस्पिरेटरी कॉज अगर आया है, पेशेंट को रेस्पिरेटरी डिसऑर्डर है, तो विल हाउ विल चेक, ठीक है। रेस्पिरेटरी डिसऑर्डर है तो एक्यूट रेस्पिरेटरी एसिडोसिस या एल्कलोसिस है, कोई भी एक्यूट फेज है, तो उसके अंदर पीएच चेंज कितना होगा, वो दैट इज द फॉर्मूला 0.008 mm पर चेंज इन PaCO2 फ्रॉम 40 से जो इसकी सेंट्रल वैल्यू है PaCO2 की, उससे कितना चेंज हो रहा है ना। अगर 1 इंक्रीज इन 1 द पीएच चेंज विल बी 0.008, अगर एसिडोसिस होगा तो डिक्रीज करेगा इतना 0.008 टाइम्स, एल्कलोसिस होगा तो इंक्रीज करेगा 0.00, बट इन एक्यूट फेज 0.008 इज द कैलकुलेशन, एंड सिमिलरली इन क्रॉनिक फेज 0.003। ये इसलिए हम कैलकुलेट कर रहे हैं कि जैसे एबीजी में पिक्चर आएगा रेस्पिरेटरी, तो रेस्पिरेटरी का चेंज देके यू कैन कैलकुलेट कि पीएच कितना होना चाहिए था इन एक्यूट फेज एंड इन क्रॉनिक फेज। सो अगर एक्यूट फेज में होगा तो जितना 40 से ऊपर अगर 50 हो गया PaCO2, तो 10 मल्टीप्लाई बाय 0.008, उतना चेंज इन पीएच में अगर होगा तो और हमारा जो मेजर्ड वैल्यू होगा एबीजी की स्लिप में, अगर उतना ही पीएच है तो इस मींस कि वो एक्यूट है ना। अगर इस कैलकुलेशन के अकॉर्डिंग होगा तो यू कैन कैलकुलेट कि यू कैन इंटरप्रेट कि वो क्रॉनिक है, ठीक है। विल सी विद द एग्जांपल। सो दिस इज एग्जांपल, PaCO2 is 80, तो 80 है मतलब हायर साइड में है ना, तो हायर साइड में है तो पीएच लोअर साइड में होना चाहिए, एसिडोसिस होगा। तो कितना चेंज हुआ है PaCO2 फ्रॉम 40 to 80 हुआ है, तो 80 minus 40 40 इंक्रीज हुआ है ना, 40 into 0.008 0.32, तो ये 0.32 डिक्रीज करेगा बिकॉज एसिडोसिस है पेशेंट में, एसिडोसिस है तो 7.4 से माइनस करेगा, ठीक है, 7.4 minus 0.32, तो 7.08। अगर उस पेशेंट का 7.08 pH होगा with this 80 PaCO2, तो this means patient is a chronic acute respiratory acidosis, acute phase में है, ठीक है। और अगर वही चीज अगर हम 0.03 से कैलकुलेट करेंगे और 0.12 आएगा और 7.28 pH रहा पेशेंट का, तो we can interpret कि patient is in chronic phase। समझ में आया? Understood? ये कैलकुलेशन इंपॉर्टेंट है टू कैलकुलेट कि वो पेशेंट, और इनके बीच में है तो एक्यूट और क्रॉनिक होगा, ठीक है, इन दोनों कैलकुलेशंस के बीच में है। एक और फॉर्मूला है, चेंज इन H plus ion डिवाइडेड बाय चेंज इन PaCO2, अगर लेस देन 3 है तो क्रॉनिक होगा, मोर देन 0.8 है तो एक्यूट फेज होगा, ठीक है। इन बिटवीन इज एक्यूट एंड क्रॉनिक, बट दिस इज फॉर ओनली फॉर रेस्पिरेटरी एसिडोसिस, नॉट फॉर रेस्पिरेटरी एल्कलोसिस। Change in H plus ion divided by change in PaCO2, the ratio is come less than 0.3, then it is chronic, more than 0.8 is the acute, okay। So similarly respiratory अगर एल्कलोसिस में होगा तो ऑब्वियसली pH बढ़ेगा, तो जो भी वैल्यूज आएगी चेंज इन pH हमें ऐड करना पड़ता है, तो एक्यूट फेज में इतना आएगा और क्रॉनिक फेज में इतना आएगा, ठीक है। इस एग्जांपल को देखो, इसको कैलकुलेट करो, तब इस 50-year-old COPD present with 7.35 है, PaCO2 is 60, बाइकार्बोनेट is 32. तो pH देखिए हमें क्या लग रहा है कि क्या है पेशेंट को, है तो नॉर्मल, लेकिन टुवर्ड्स द एसिडोसिस साइड में 7.4 से लोअर साइड में है, तो टुवर्ड्स एसिडोसिस है, ठीक है। And PaCO2 is 60 and bicarbonate is 32. So pH and bicarbonate is in opposite direction. क्योंकि pH कम हो रहा है, bicarbonate बढ़ रहा है, तो वो मेटाबॉलिक नहीं होगा, बिकॉज मेटाबॉलिक होने के लिए दोनों सेम डायरेक्शन में जाते हैं, तो दोनों डिक्रीज करते हैं, दोनों इंक्रीज करते हैं, इसमें उल्टा है। एंड इन सी PaCO2 बढ़ा हुआ है, इंक्रीज है, और pH लोअर साइड मींस अपोजिट डायरेक्शन में। तो कॉज इज द प्राइमरी इज द रेस्पिरेटरी कॉज। अब रेस्पिरेटरी आ गया तो हमें देखना पड़ेगा कि एक्यूट है या क्रॉनिक है। तो अगर हम इसको 0.008 से मल्टीप्लाई करते हैं कितना आएगा, 60 माइनस 40 20 इंटू 0.008 कितना आएगा, 0.16। तो एसिडोसिस है तो 7.4 माइनस 0.16 कितना है, 7.2, बट ये 7.35 है, तो एक्यूट तो नहीं होगा, है ना, समझ में आया, ये एक्यूट तो नहीं है। आप क्रॉनिक के लिए चेक करते हैं तो 20 into 0.003 कितना है, 0.06, 7.4 minus 0.06 कितना है, 7.34, मतलब क्रॉनिक केस है, क्रॉनिक रेस्पिरेटरी एसिडोसिस है, समझ में आया। नाउ यू कैन कैलकुलेट ना कि एक्यूट है कि क्रॉनिक है, कैलकुलेशन से यू कैन अंडरस्टैंड। वैसे यू कैन अंडरस्टैंड द हिस्ट्री आल्सो, दैट्स व्हाई द इम्पोर्टेंट, द निमोनिया था बट एक्यूट एब्जॉर्बेशन के साथ है, तो निमोनिया की वजह से क्रॉनिकली हाइपरटेंशन करेगा होगा, बट एक्यूट के साथ आया तो इसलिए इमरजेंसी में आया, तो लेकिन इसको अंदर क्रॉनिकली फेज में हो गई है, ठीक है। एंड कैलकुलेशन से भी क्या कैलकुलेट, सेकंड नीचे देखो 7.25 है, PaCO2 is 60 and bicarbonate is 26। एक्यूट क्या है, एक्यूट रेस्पिरेटरी एसिडोसिस को आगे कैलकुलेट करना, इस एग्जांपल को याद कर लेना, आगे भी हम इसको निकालेंगे, ठीक है, इसी एग्जांपल को फॉलो करेंगे। इसमें एक और चीज है, तुम डायरेक्टली भी देख सकते हो, इसको कैलकुलेट करो, देखो क्या है, 20-year-old girl with anxiety disorder presented with the breathing difficulties, pH was increasing side, bicarbonate was decreasing side, मतलब opposite direction में, तो metabolic नहीं हो सकता, and this is on the opposite direction, obviously the cause is respiratory alkalosis। तो इसमें pH में हम ऐड करेंगे जो भी वैल्यू आएगा, तो देखो इसमें एक्यूट है कि क्रॉनिक है, पहला वाला एक्यूट आया सबका, तो एक्यूट रेस्पिरेटरी एल्कोहोलिसिस, नीचे वाला कैलकुलेट करो, क्रॉनिक रेस्पिरेटरी एल्कोहोलिसिस, ठीक है, अंडरस्टैंड, पीछे समझ में आ रहा है पक्का, और कर जाके मत कहना कि कुछ समझ नहीं आया, ऊपर सारा कैलकुलेशन नहीं करो ना, बहुत सारे नंबर्स आएंगे, अभी आगे बहुत नंबर आएंगे। अभी हम बेसिक में, अभी हमने सिर्फ इतना देखा है कि वेदर विल बी एबल टू इंटरप्रेट कि एसिडोसिस है एल्कलोसिस, वो हमने देखा, एसिडोसिस है एल्कलोसिस वो हमने देखा, उसके बाद विल गो विद द रेस्पिरेटरी या मेटाबॉलिक है, वो तुम्हें पता चलेगा कैसे देखते हैं ना, एंड देन उसके बाद अगर रेस्पिरेटरी है तो एक्यूट है या क्रॉनिक है, ठीक है। अभी तक हमने इतना ही देखा है, और उससे ऊपर सबसे इंपॉर्टेंट है कि FiO2 होना चाहिए, पेशेंट का SpO2 भी होना चाहिए इंटरप्रेट करने के लिए। Then we'll look for the compensation, either respiratory है तो metabolic compensation ठीक है कि नहीं है, अगर है तो पूरा complete है कि नहीं है, ठीक है, adequate compensation है कि नहीं है। So if primary disorder is respiratory acidosis, there will be increase in PaCO2, increase in PaCO2 होगा, ये सबको पता है। अगर रेस्पिरेटरी एल्कलोसिस होगा तो डिक्रीज PaCO2 होगा, मेटाबॉलिक एसिडोसिस है तो डिक्रीज बाइकार्बोनेट, और मेटाबॉलिक एल्कलोसिस है तो इंक्रीज बाइकार्बोनेट, दैट इज द प्राइमरी चेंज, ठीक है। और कंपनसेटरी चेंज में जो होगा, ऑलवेज रिमेंबर द कंपनसेटरी चेंज, जिस साइड प्राइमरी पैथोलॉजी था उस साइड कंपनसेटरी भी होगा, सेम साइड में। अगर इंक्रीज PaCO2 है तो बाइकार्बोनेट विल बी इंक्रीज इन कंपनसेशन, डिक्रीज PaCO2 है तो बाइकार्बोनेट विल डिक्रीज, फॉर कंपनसेशन, ठीक है। सेम मेटाबॉलिक आल्सो अगर डिक्रीज बाइकार्बोनेट है तो PaCO2 विल इंक्रीज, ठीक है। So this is the crux की compensatory response and the primary response will always move in the same direction, okay. So let's see, this is the respiratory disorder. So metabolic compensation होगा, तो metabolic compensation for respiratory disorder will there is a rule 1425, ठीक है। In acute phase in acidosis or in respiratory acidosis, in acute phase the rule is 14, ठीक है, and in alkalosis the rule is 25. 14 is in acute respiratory disorder every 10 change of PaCO2 from its 40 level, मतलब increase in PaCO2 of 40 PaCO2 from 40 every 10, suppose 50 हो गया तो there will be one increase in the increase in the bicarbonate, because PaCO2 in on the higher side the bicarbonate will also increase, ठीक है। So अगर 50 हो गया PaCO2 तो bicarbonate will go to 25, अगर 60 हो जाएगा तो bicarbonate will go to 26. But in acute phase अगर यही acute respiratory acidosis अगर यही chronic होगा like 50 PaCO2 होगा तो the bicarbonate will increase by 4 in chronic phase, ठीक है। तो अगर 50 है PaCO2 तो bicarbonate will increase to 28, अगर हमारा 60 हो गया तो bicarbonate will become 32, okay. Similarly in respiratory alkalosis every 10 degrees of PaCO2 from 40 there will be a decrease in bicarbonate by 2, like 40 से 30 हुआ PaCO2 तो bicarbonate will become 22, 20 हो गया तो bicarbonate will become 20 in acute respiratory alkalosis. And similarly acute chronic respiratory alkalosis every 10 degrees of bicarbonate PaCO2 will decrease by 5. So अगर 30 होता है in chronic phase तो bicarbonate will become 90, ठीक है। अगर हमने पिछला वाला एग्जांपल में देखा होगा this was the acute ना, ये acute था, acute respiratory acidosis था। So 60 है तो मतलब 20 चेंज है तो bicarbonate is 26, okay. और similarly here this was the chronic phase तो 20 increase है, 20 है तो 8 will increase ना, because this is chronic respiratory acidosis, that's why the bicarbonate is 30, okay. Similarly you can calculate, this is the same example, PaCO2 is 60, increase is 20, so 20 into 0.12 का increase होगा तो 20 plus 2 26 हो जाएगा, chronic होगा 32 हो जाएगा, ठीक है। और ये alkalosis के लिए अगर 25 हो गया PaCO2 तो change is 15, 15 से change हुआ है तो 15 से मतलब acute phase में 0.2 से multiply करेंगे तो 3 का decrease होगा bicarbonate, तो the measured bicarbonate will be 21 calculated bicarbonate, and chronic respiratory alkalosis PaCO2 is 15, so the measured bicarbonate should be 16.5, okay. बट अगर मेटाबॉलिक कंपोनेंट है तो रेस्पिरेटरी कंपनसेशन जो होगा उसके लिए कैलकुलेट करने के लिए देते हैं फॉर्मूला, द विंटर्स फॉर्मूला। तो विंटर्स फॉर्मूला क्या कहता है, इन एक्यूट इन मेटाबॉलिक एसिडोसिस द एक्सपेक्टेड PaCO2 शुड बी 1.5 into बाइकार्बोनेट प्लस 8 और जो भी वैल्यू आएगा उसका प्लस माइनस 2 होगा, ठीक है। एंड सेम इन मेटाबॉलिक एल्कलोसिस द एक्सपेक्टेड PaCO2 is 0.7 into बाइकार्बोनेट प्लस 21, ये फॉर्मूला याद कर लेना, ठीक है, ओके। प्लस माइनस 2 इधर लिख लिया गया लोगों ने, चलो लिख लो इसको, आगे बहुत कैलकुलेशन आएगी, काम कर चलेंगे, ठीक है। ओके यूज दिस पेपर ना, बिकॉज़ आगे बहुत कैलकुलेशन आने वाली है, टू राइट इट, ओके। सो बाइकार्बोनेट इज 10 मतलब मेटाबॉलिक एसिडोसिस में है तो एक्सपेक्टेड PaCO2 कितना होगा 1.5 into 10 that is 15 plus 23, निकालो 20-year-old boy with type 1 diabetes mellitus presented with a blood sugar of 350 and feeling restless. PaCO2 is 30, pH is 35, PaCO2 is 35 and bicarbonate is 20. So what is the primary disorder? What is the primary disorder here? क्या है primary disorder क्या है? समझ में आया है आप लोगों को? ये ऐसी करते हैं लाल मेटाबॉलिक एसिडोसिस क्यों है? इसका निकालो कैसे आएगा कंपनसेशन? क्यों कैसे है दोस्त मेटाबॉलिक एसिडोसिस? पीएच कितना है? इसका मतलब क्या है? मतलब है तो नॉर्मल बट टुवर्ड्स द एसिडोसिस साइड है ना? लाइक 1.4 से है टुवर्ड्स द एसिडोसिस साइड बट स्टिल नॉर्मल है वो कंपनसेशन बेस नॉर्मल में है लेकिन टुवर्ड्स एसिडोसिस साइड में अभी एंड देन बाइकार्बोनेट इज 20 मतलब 24 से कम है pH भी ऑन लोअर साइड में बाइकार्बोनेट भी लोअर साइड में है तो बस सेम डायरेक्शन में मूव कर रहा है तो प्राइमरी पैथोलॉजी मेटाबॉलिक एंड एसिडोसिस की साइड है तो मेटाबॉलिक एसिडोसिस तो मैं पक्का तो मेटाबॉलिक एसिडोसिस में है तो इसमें हम कंपनसेशन किस चीज का देखेंगे रेस्पिरेशन का रेस्पिरेटरी विल बी कंपनसेटेड तो मेटाबॉलिक एसिडोसिस के लिए विल्टर फॉर्मूला क्या था लिखा था ना 1.5 into बाइकार्बोनेट प्लस 8 1.5 into bicarbonate कैलकुलेट कितना है 1.5 into 20 कितना हुआ 3 plus 8 11 है ना 11 20 into 1 point कितना होगा 1.5 30 हो गया ना 30 plus 8 38 होगा ना 38 plus minus 2 मतलब 36 के आसपास होना चाहिए था तो 35 है वेल कंपनसेटेड है ना तो इट्स ए वेल कंपनसेटेड रेस्पिरेटरी कंपनसेशन जिसका सेकंड वाले में हाँ तो मतलब इट्स आल्सो वेल कंपनसेटेड ठीक है रेस्पिरेटरी कंपनसेशन इज एडिक्वेट तो अगर रेस्पिरेटरी अगर मेटाबॉलिक डिसऑर्डर में इसमें ध्यान से देखोगे जी इसमें एक और चीज छुपा हुआ है कि अगर पेशेंट इज मेटाबॉलिक कंपोनेंट आइदर मेटाबॉलिक एसिडोसिस और एल्कलॉसिस द रेस्पिरेटरी कंपनसेशन इज एडिक्वेट व्हेन PaCO2 is equal to the last two digit of the pH nearly about same है मतलब adequate compensation होगा तो मतलब you can directly this is a trick अगर you can see ठीक है तो ध्यान से देखो ओके so अगर ये equal है तो मतलब nearly तुम्हारा compensation adequate है आसपास है लास्ट डिजिट के either you can calculate with the Winter formula also एग्जाम में आता है Winter formula MCQs में आ सकता है तो अगर मेटाबॉलिक यहाँ तक हमें समझ में आ गया पहले हमने देखा कि पेशेंट एसिडोसिस या एल्कलॉसिस में है देन मेटाबॉलिक है कि रेस्पिरेटरी या प्राइमरी डिसऑर्डर क्या है तो प्राइमरी डिसऑर्डर जो भी है तो कंपनसेशन एडिक्वेट है कि नहीं है ठीक है एंड देन अगर मेटाबॉलिक डिसऑर्डर है प्राइमरी डिसऑर्डर इज मेटाबॉलिक देन वी हैव टू फाइंड द एनाइन गैप ओके तो एनाइन गैप कैसे निकालते हैं व्हाट इज द एनाइन गैप So body के अंदर is a balance between cation and anions. So there are unmeasurable anions also in the body like proteins, sulfates, albumin. ठीक है? तो वो अगर बढ़ जाएंगे तो बॉडी के अंदर तो मेटाबॉलिक कंपोनेंट ज़्यादा बढ़ जाएगा तो हाई एनाइन के मेटाबॉलिक एसिडोसिस होने के चांसेस होते हैं. So this is very important कि जब भी बॉडी के अंदर एसिडोसिस बढ़ता है जैसे डायबिटिक एसिडोसिस बॉडी उसको कंपनसेट करने के लिए इसको इक्वेशन को पॉजिटिव और नेगेटिव बैलेंस करने के लिए अपनी बॉडी से बाइकार्बोनेट को रिलीज कर देता है टू मेंटेन दैट इलेक्ट्रोन्यूट्रलिटी तो दैट इज वेयर द इंपॉर्टेंस ऑफ द एनायन गैप तो एनायन गैप बढ़ता रहेगा ठीक है वो बाइकार्बोनेट को उतना यूज करता रहेगा टू अकोमोडेट दैट अनवांटेड एसिड्स ठीक है सो इसको निकालने के लिए सिंपल तरीका है सोडियम द कैटायन माइनस एनायंस मेजर्ड कैटायन माइनस एनायन जो मेजर कैटायन है ठीक है मेजर कटायन बॉडी के अंदर सोडियम है माइनस क्लोराइड एंड बाइकार्बोनेट, तो इट इज कम्स अराउंड 12 प्लस माइनस 4, मतलब आइदर 8 to 16 के बीच में जो भी आएगा दैट इज नॉर्मल एनाटॉमी। बट ये डिपेंड करता है एल्बुमिन के ऊपर भी, एल्बुमिन अगर कम होगा तो ऑब्वियसली ये कम हो जाता है, सूडो कम हो जाएगा, तो इसलिए यू हैव टू करेक्ट विद द एल्बुमिन आल्सो, ठीक है। तो 2.5 टाइम्स ऑफ द एल्बुमिन जो भी तुम्हारा आया है, सपोज करो एल्बुमिन 1 है, पेशेंट का एल्बुमिन सीरम एल्बुमिन इज 1, तो वी हैव टू कैलकुलेट द करेक्टेड एनायन गैप, ठीक है। तो उसके लिए कैसे निकालेंगे, 4 हम स्टैंडर्ड वैल्यू लेते हैं एल्बुमिन का, तो 4 माइनस जो भी मेजर्ड एल्बुमिन है, लाइक इस केस में 1 था पेशेंट का, तो 4 माइनस 1 इज 3, तो 3 मल्टीप्लाई बाय 2.5 कितना है 7.5, 7.5 प्लस व्हाटएवर जो भी कैलकुलेट एनायन गैप आएगा उसमें हमें उसको ऐड करना है। सपोज 12 आया, 12 प्लस 7.5 तो इट्स 19.5, तो उसका करेक्टेड एनायन गैप विल बी 19.5, ओके। तो 2.5 is the value you have to calculate, remember, okay. So there are various causes of the high anion gap and normal anion gap, ठीक है। normal anion gap acidosis, high anion gap asthma and asthma, normal anion gap acidosis is asthma and high anion gap metabolic acidosis is asthma. So what are the causes for the high anion gap? Formula उसका निमोनिक गैस, मड पाइल्स, फिनॉल पॉइजनिंग, यूरेमिया, डायबिटिक कीटोएसिडोसिस, पैराल्डिहाइड पॉइजनिंग। और नॉर्मल एनायन गैप के कॉजेस क्या है, गैस्ट्रिक, वॉमिटिंग, डायरिया, है ना, और वो हो गया तुम्हारा अगर तुमने बहुत सोडियम एनएस नॉर्मल सलाइन दे दिया तो, ठीक है, कैन बी द नॉर्मल एनायन गैप मेटाबॉलिक। तो उसके बाद हम डेल्टा रेशियो देखते हैं कि तो व्हाटएवर द चेंज इन द एनायन गैप एंड द बाइकार्बोनेट दैट विल गेट और नॉट, दैट इज डेल्टा रेशियो, दैट इज आल्सो कॉल्ड गैप रेशियो, ठीक है। तो वो सिंपल है, हमारा मेजर एनायन गैप माइनस नॉर्मल एनायन गैप डिवाइडेड बाय द नॉर्मल बाइकार्बोनेट माइनस मेजर बाइकार्बोनेट। तो मेजर एनायन गैप व्हाट इफ यू कैलकुलेट माइनस नॉर्मल एनायन गैप विल मेक इज 12, सिमिलरली नॉर्मल बाइकार्बोनेट को कैलकुलेट 24 माइनस जो भी पेशेंट का बाइकार्बोनेट है, तो इनका जो भी रेशियो होगा उसको हम डेल्टा रेशियो कहते हैं। सो डेल्टा रेशियो की वेरियस वैल्यूज 1 to 2 के बीच में है तो पेशेंट विल बी अ प्योर हाई एनायन गैप मेटाबॉलिक एसिडोसिस। अगर लेस देन 1 है तो पेशेंट कैन हैव हाई एनायन गैप और नॉर्मल एनायन गैप मेटाबॉलिक एसिडोसिस, लेकिन अगर लेस देन 0.4 आया तो वो नॉर्मल एनायन गैप मेटाबॉलिक एसिडोसिस ही होगा। एंड सिमिलरली अगर 0.2 से ऊपर आया रेशियो तो हाई एनायन गैप मेटाबॉलिक अलोंग विद द कंकरेंट मेटाबॉलिक एल्केलॉसिस, उसके अंदर मेटाबॉलिक एल्केलॉसिस भी चल रहा है साथ साथ, ठीक है। तो रेशियो इज वेरी इंपॉर्टेंट, ये हम आगे कैलकुलेट करेंगे। एंड फाइनली लुक फॉर PO2, PO2 भी देखना है कि हाइपोक्सीमिया में है कि नहीं है पेशेंट, ठीक है। वो विल स्किप बिकॉज़ बहुत सारे यूजीज है, जिसको पढ़ना होगा तो मैं बस पढ़ लिया है, बता दूंगा, ठीक है। वो थोड़ा डिफिकल्ट हो जाएगा, बाकी कुछ बच्चे समझे। तो विल सी दिस इज द ABG इंटरप्रेट करो इसको। ABG है FiO2 is 0.6, मतलब 60% ऑक्सीजन पेशेंट है, pH is 7.37, PaCO2 is 27.4 and PO2 is 260, bicarbonate is 16.2। so pH towards the lower side में है, PaCO और bicarbonate is towards the lower side, मतलब both are in the same direction, and PaCO2 भी lower side में है, लेकिन रेस्पिरेटरी कॉज होने के लिए अपोजिट साइड को होना चाहिए था। रेस्पिरेटरी तो नहीं होगा, प्राइमरी डिसऑर्डर, प्राइमरी डिसऑर्डर विल बी मेटाबॉलिक एसिडोसिस। तो ये देख लिया हमने कि प्राइमरी मेटाबॉलिक एसिडोसिस है, आगे मेटाबॉलिक एसिडोसिस है तो फिर हम क्या चेक करते हैं, कंपनसेशन किस चीज का, रेस्पिरेटरी का। कैसे कैलकुलेट करेंगे, विंटर्स फार्मूला। तो एसिडोसिस है तो फार्मूला क्या होगा, तो कैलकुलेट करके बता सकते हैं इसका कितना होना चाहिए था एक्सपेक्टेड PaCO2 इसमें, कितना कैलकुलेट करें तो एकदम इसको शांत करके कौन फाइनल सिर्फ जूनियर है लोग सब खड़े हैं कितना है कैलकुलेट करो फटाफट आया कैलकुलेशन इसे दिया था तो पहले 1.5 into बाइकार्बोनेट कितना 30.3 माइनस लेकिन इसका 27 है। तो पहला तो इंटरप्रिटेशन हुआ कि एडिक्वेट नहीं है, और क्या हुआ इसका मतलब क्या है कि जितना होना चाहिए था कि उससे भी कम है, मतलब पेशेंट ज्यादा हाइपरवेंटिलेट कर तो एल्कलॉसिस है, तो रेस्पिरेटरी एल्कलॉसिस की साइड गया है ना। तो ये आ गया मेटाबॉलिक एसिडोसिस विद रेस्पिरेटरी एल्कलॉसिस, अभी तक ये आया हमारा है ना। तो और मेटाबॉलिक एसिडोसिस आ गया, तो अपने नेक्स्ट स्टेप क्या था आफ्टर कंपनसेशन, एनायन गैप निकालो इसका। इलेक्ट्रोलाइट्स दिया हुआ है, सोडियम 145 माइनस 109 माइनस 17 या 16 से कैलकुलेट कर सकते हैं। सबका है 20 के करीब। तो हाई एनायन गैप मेटाबॉलिक एसिडोसिस हुआ इसका मतलब, ठीक है। तो हाई एनायन गैप मेटाबॉलिक एसिडोसिस हुआ, तो इसके एक बार डेल्टा रेशियो भी निकालो। अब नेक्स्ट स्टेप इज डेल्टा रेशियो 20 माइनस 12 डिवाइडेड बाय 24 माइनस 16। क्या है 1 और 2 के बीच में है, मतलब प्योर हाई एनायन गैप एसिडोसिस है ना। एंड इसका PO2 भी हमारा, और जितना हम ऑक्सीजन दे रहे हैं ना उसको 5 टाइम्स PO2 होना चाहिए, लगभग 4 to 5 टाइम्स। तो लगभग नॉर्मल ही है, मतलब लंग में कोई पैथोलॉजी नहीं है इसका। जितना ऑक्सीजन दे रहे हो उतना उसका PO2। तो हमारा इंटरप्रिटेशन क्या होगा फाइनल, प्राइमरी मेटाबॉलिक एसिडोसिस या हाई एनायन गैप मेटाबॉलिक एसिडोसिस रेस्पिरेटरी एल्कलॉसिस। पहुंच गए यहाँ तक हम लोग। तो सेकंड एनालिसिस देखो, शुरू करो। रिफ्रेश करो, रिफ्रेश। निकालो, बताओ, लिख कर रखो, याद करो। आ गया, निकल गया। हो गया।
देखिए वो कल नहीं कर
क्या है प्राइमरी इसमें क्या है प्राइमरी रेस्पिरेटरी एसिड बोल रहे हैं बच्चे वाई का क्या है प्राइमरी क्या है प्राइमरी क्या होगा प्राइमरी रेस्पिरेटरी मेटाबॉलिक इधर से मेटाबॉलिक बोल रहे हैं अब ये मेटाबॉलिक बोल रहे हैं क्यों मेटाबॉलिक नहीं हो सकता वाई मेटाबॉलिक क्या वो बर्ड से अभी रेस्पिरेटरी है वाई का देखो पीएच कितना है ना बहुत ज्यादा है 48 है पीएच इट्स व्हाट नॉर्मल इतना चेंज कैन नॉट कॉज दिस सिवियर रेस्पिरेटरी दिस सिवियर रेस्पिरेटरी एंड वाई का तो काफी ज्यादा चेंज कवर प्राइमरी विल बी द मेटाबॉलिक की वजह से मेटाबॉलिक इज द प्राइमरी डिसऑर्डर समझ में आया कि वाई प्राइमरी इज मेटाबॉलिक नाउ आप नेक्स्ट करो प्राइमरी इज मेटाबॉलिक है अब क्या होगा संदीप
कॉम्पनसेशन है कि नहीं
तो चेक करो बोलने से क्या होगा निकाल के बताओ पेशेंट्स क्लिनिकल PSU not that much high or that severe PSU 7.1 patient just 40 days PSU to normal is 35 towards normal and by God what is the change what is the metabolic clinical case कितना आया अरे कंपनसेशन क्या है
नहीं सर वो कंपनसेट नहीं हो
क्या है
साथ में रेस्पिरेटरी एसिडोसिस
क्या निकला आई 9 के
metabolic acidosis with respiratory acidosis.
सेकंड स्टेप आ गया कितना है तुम्हारा एक्सपेक्टेड PSU 35 to 39 इसका 35 to 39 आ रहा है आप लोगों के साथ इसका क्या मतलब है लेकिन पेशेंट तो 48 है 49 मान के चलो तो मतलब क्या मतलब हुआ कि एडिक्वेट कंपनसेशन तो नहीं है क्या लेकिन PSU 49 है इसका मतलब क्या हुआ एसिडोसिस भी है रेस्पिरेटरी एसिडोसिस भी है अभी पेशेंट का CO2 हायर साइड में ही है मतलब जैसे वेंटिलेटरी फेलियर आल्सो पेशेंट इज नॉट एबल टू हाइपर वेंटिलेट दैट मच CO2 ठीक है तो इसमें मेटाबॉलिक एसिडोसिस के साथ रेस्पिरेटरी एसिडोसिस में भी है पेशेंट उसके बाद मेटाबॉलिक एसिडोसिस निकाला था उसके बाद और क्या निकालना है नाइन कैप निकालो नाइन कैप उसके बाद आगे for gap in gap ratio delta ratio कितना है ये तेज आइए लाइन के मेटाबॉलिक डेल्टा रेशियो कितना है 2.3 का क्या मतलब प्रेशर हुआ क्या होगा मिक्स है तो एनायन गैप के साथ साथ मेटाबॉलिक एसिडोसिस के साथ साथ देयर विल बी अ मेटाबॉलिक एल्कलॉसिस आल्सो तो
Good afternoon, judges. I am Dr. Amita Das, Junior Resident, Department of General Medicine at JMS Patna. And today I am going to present a case of demyelinating polyneuropathy in type 2 diabetes mellitus, which we diagnosed as CIDP. The title of the poster is Not Every Neuropathy in Diabetes is Diabetic. A case of CIDP presenting with sensory ataxia in a patient of type 2 diabetes mellitus. We encountered a 40-year-old male patient who had a history of 10 years history of diabetes mellitus, who came with 2-month history of walking instability, which was initially limited to heart surfaces and which gradually progressed to being unable to walk on uneven surfaces such as stairs. And it was more, and with time it was more pronounced, and gait instability was also present at night. And he also had symptoms of numbing and tingling in both feet, which were also more pronounced in the dark. There was no history of any vertigo, dysarthria, limb weakness, bowel or bladder dysfunction, and cranial nerve involvement or visual symptoms. At this point, given the history of type 2 diabetes mellitus, we were considering an initial diagnosis of large fiber sensory polyneuropathy, and on further examination, a neurological examination revealed an intact higher mental function with and motor examination revealed normal bulk, tone, and power, and reflexes were reflexes across all 4 limbs were hyporeflexic, with and sensory examination revealed impairment in joint and in joint sense, position sense, and a positive Romberg sign. On gait examination, a broad-based sensory ataxic gait was seen. Cerebellar examination was normal, and cranial nerve examination was also normal. On further workup, routine blood investigations such as CBC, LFT, KFT, vitamin B12 levels, thyroid profile, and MRI spine were unremarkable. We also conducted a nerve conduction study which showed a conduction block with F-wave latencies and slowed conduction velocities. At this time, we were also considering the possibility of CIDP in this patient given the duration and typical findings on the nerve conduction study. And we performed a CSF study which demonstrated albuminocytological dissociation, which also supported the diagnosis of CIDP. We planned the management with oral corticosteroids, and glycemic control was optimized, and structured physiotherapy with gait and balance training was done, and this resulted in marked improvement in gait and functional status, thus making the final diagnosis as chronic inflammatory demyelinating polyneuropathy presenting a sensory ataxia in a patient with type 2 diabetes mellitus. The importance of this case is that not all types of sensory ataxia in a type 2 diabetes mellitus patient should be considered as polyneuropathy. We should always keep our mind open for other diagnoses and conduct a thorough follow-up, thorough workup through and also an NCV. NCV was prompted due to generalized hyperreflexia with typical CSF studies demonstrating albuminocytological dissociation, and the final diagnosis was made on the basis of the NCV findings, which showed conduction block, temporal dispersion, and prolonged F-wave latencies. Hence, early diagnosis and timely initiation of immunotherapy in this patient resulted in a significant neurological recovery, and it also prevented long-term disability.
What is the uniqueness in your topic you have selected for this poster presentation?
Sir,
Mostly, whenever a patient presents with numbness and tingling in a long-standing case of type 2 diabetes mellitus, we always label it as uh, diabetic neuropathy. But in this case, since there was a history of gait disturbance which was progressive in nature, it was just present on hard surfaces, then it went on to uneven surfaces and also progressed in the dark. So this particular feature prompted us to do further workup, and we had to consider other demyelinating disorders as our differential diagnosis.
So when CIDP should be suspected in a case of diabetic polyneuropathy? Means what are the features which distinguish it from diabetic polyneuropathy?
Sir, a long course, like 8 weeks course, sir, and sir, hyperreflexia, hyperreflexia, and sir, mostly diabetic polyneuropathy is mostly distal, and this was also this involved both proximal and distal, patterns, sir. Some from posterior collar dysfunction, sir. Sir, gait instability. Sir, mostly in posterior column lesions in diabetic neuropathy, sir, it's mostly distal predominant. We had, sir, both proximal involvement, all 4 limbs, sir. Yes, sir. Yes, sir. Yes, sir. Ataxia is more commonly seen in, sir, CI, posterior column. Yes, sir. Sir, in sensory ataxia, sir, sir, this is more CIDP. Sir, we suspected CIDP since this was more progressive in nature. Sir, sensory ataxia tends to be a little more, sir, dramatic and more distal predominant. जी सर, सर एनसीवी के बेसिस पे फाइनल डायग्नोसिस बनाया हम लोगों ने. एनसीवी के बेसिस पे सर फाइनल डायग्नोसिस था. So Romberg's positive, Romberg's.
Good. How you have?
Yes, sir. Yes, sir.
How you have treated this case? Okay, you can continue. How you have treated this case?
Sir, we initially decided to treat with IVIG, given the fact that this was a diabetic patient and we did not want the glucose to, we wanted optimal glycemic control. But since this patient, it was not available in the hospital at the time, and the patient could not afford to bring it from outside, so we went with corticosteroids, and we discharged on a long-term plan. He came back in follow-up after around 2 months, and there was significant neurological improvement, sir.
What is the first choice for treating the CIDP?
Sir, IVIG, sir.
IVIG. In CIDP.
Corticosteroid. Corticosteroid, sir, sorry.
Okay, good. No.
Thank you. Thank you for good presentation from your side. The next person.
हाँ
अंकिता भारती.
ये वाला है.
A very good afternoon to judges and everyone present here. I'm Dr. Ankita Bhati, junior resident first year from IGMS Patna, and my poster presentation is on the topic a case of non-ketotic hyperglycemia hemogloria. A 62-year-old female who was a known case of type 2 diabetes mellitus since 10 years presented with a sudden onset involuntary movement of the right upper limb and face for 2 days. Movements were irregular and non-rhythmic in nature, involuntarily and continuous. And in the previous history, there was no history of fever, seizures, or loss of consciousness, or any drug history or alcohol intake. On clinical examination, patient was conscious and oriented to time, place, and person. All the vital parameters were stable. On neurological examination, only the continuous coriform movement were noted on the right side of the body, and motor power were preserved in all 4 limbs, and superficial and deep reflexes were present, and no sensory deficit was found. On investigation, random blood glucose was 420 milligram per deciliter, HbA1c was in the level of 12.4, and on urine examination, glucose was present but ketone bodies were absent in the urine examination, and urine albumin and creatinine ratio was found to be 45 milligram per gram. On following examination and observation, first CT scan was done, which showed hyperintensity in the left side of the basal ganglia region, and on MRI, T1 weighted hyperintensity was noted on the left basal ganglia, and these findings on ruling out all the other possibilities were consistent with the condition known as diabetic striopathy. The patient was managed intensively on insulin therapy, and for symptomatic control, low-dose haloperidol was given. Regular monitoring of blood glucose was done, and there was gradual improvement in abnormal movements of the body. Significant reduction in the coriform movements within 5 days was noted, and patient was diagnosed and discharged with improved glycemic control. So this case was related to non-ketotic hyperglycemia hemogloria, which is a very rare complication of uncontrolled diabetes mellitus, and this was most probably the causes include vascular or metabolic dysfunction in the patients of uncontrolled hyperglycemia. So it is a rare but reversible neurological complication of uncontrolled diabetes mellitus. Early diagnosis and prompt treatment, including the glycemic control, can lead to rapid clinical recovery.
What are the other differences and how you can comment that this is due to uncontrolled hyperglycemia?
So the first most important differential diagnosis will be ischemic or hemorrhage, intracranial hemorrhage. So on the basis of neurological examination and the presence of superficial and deep reflexes and sensory examination, that can be ruled out. The other differential diagnosis can be either like if the patient is 62-year-old, first we should consider any drug history like levodopa, induced tremor, chorea-form tremor, and if age is less than 62 or younger age, we can consider like Huntington syndrome, and we can have other causes of abnormal movements.
So at the time of discharge, patient improved completely?
No, sir. So some improvement were there, but it almost takes 5 to 6 months for complete recovery.
What are the role of any anti-epileptic drug in this case? Because I have seen one case against Patna. These 2 anti-epileptic drugs were added. Then, apart from strict glycemic control, anti-epileptic drugs were also added. What are the role of anti-epileptic drugs?
So for symptomatic management and for complications, if the abnormal body movement.
What's the exact pathology or what's the exact mechanism behind this?
So there are two theories proposed for this. First can be vascular or other can be metabolic. So in metabolic, it is mainly in non-ketotic hyperglycemia patients. When the ketone bodies are not present mainly due to the GABA uh, GABA neurotransmitter, and the striatal region, which includes the caudate lobe and which mainly controls the motor functions of the body. So if GABA is reduced in the body, then the globus pallidus externa's inhibition is reduced. So that's why the next pathway which follows, like substantia strata nucleus, so then the inhibition to the thalamus is reduced, and then due to excessive projection of the fibers towards the thalamus, the movements are increased.
Right. Have you followed this patient?
Yes, sir. In the OPD follow-up, patient has come and the symptoms has reduced gradually with glycemic control.
What are the chances of recurrence? Suppose the patient recovers completely, then what are the chances of recurrence? If glycemic control worsens in future, then it will recur or not?
So it can recur.
Yes, it may recur.
Yes.
I have seen some recurrence of this case.
It's okay. Thank you.
Thank you, sir.
Hemicoria and hemicoria. Kajal Kumari, can you please come up and start with your poster part?
कौन सा है ये
नहीं ये वाला नहीं है
ये
नहीं डायबिटीज मेलाइटिस ये वाला काजल कुमारी MBBS intern of RDGM Medical College and Hospital Turki Muzaffarpur. I am here to present my poster on the topic of diabetes mellitus, a lifelong challenge, a preventable burden. This poster has been prepared under the guidance of Dr. Abhijit Kumar sir, Associate Professor General Medicine, and Dr. Prachi Priya ma'am, Associate Professor PSM Department, RDGM Medical College and Hospital. So I will start with the introduction. Diabetes mellitus is a chronic metabolic disorder characterized by the persistent hyperglycemia resulting from the defects in insulin secretion and its function, or it can be both. It is associated with the long-term damage and dysfunction and failure of the various organs, like especially eyes, kidney, nerves, heart, and blood vessels. Diabetes mellitus is the major global health problem which is affecting more than 537 million people worldwide. According to IDF 2021, good glycemic control and early detection of the disease will help to prevent the complication and reduce the morbidity as well as the mortality ratio. Case summary: a 47 years old male presented to the medicine OPD with a complaint of fever, generalized weakness along with the tingling sensation of lower limb from past 5 days. The patient was apparently well before, then diagnosed with type 2 diabetes mellitus 5 years back. Initially, he was treated with metformin, but due to inadequate glycemic control, other OHs were also added. In a view of persistent poor glycemic control, despite oral anti-diabetic therapy, insulin was subsequently initiated using a basal bolus regimen. Now, moving towards the clinical examination, the general examination shows that the patient is conscious, cooperative, well-oriented to the time, place, and person. There is no presence of pallor icterus, clubbing, cyanosis, lymphadenopathy, and any significant edema. Fundus examination revealed that the person is having mild non-proliferative diabetic retinopathy. In neurological examination, neurological examination revealed that there is a reduced ankle jerk reflex bilaterally with preserved knee reflexes. The findings were suggestive of distal asymmetrical peripheral neuropathy. No foot ulceration was noted. In laboratory investigation, the investigation reports are the patient is having fasting plasma glucose level is 125 mg per dl, postprandial glucose level is 262 mg per dl, HbA1c is 13.5%, serum creatinine level is 3 mg per dl, eGFR is 20.9 ml per minute, and urine albumin creatinine ratio is 16.3 mg per dl. Now these are the three images of the patient, which the first one is showing the fundoscopic examination. The fundus photograph showing the mild non-proliferative diabetic retinopathy. Second is the insulin which is taken by the patient on the regular basis, which is in the basal bolus regimen. And third is the report of HbA1c report, which is showing the result is 13.5% level over the past 2 to 3 months. Overall interpretation, the clinical and laboratory findings indicates the poorly controlled diabetes mellitus with microvascular complication including the mild non-proliferative diabetic retinopathy and peripheral neuropathy, along with the significant dysfunction, the markedly elevated HbA1c and reduced eGFR indicates there is a need of close glycemic monitoring and comprehensive renal and diabetic management. Conclusion, my patient Mr. Vishwanath Kumar is prolonged case of diabetes mellitus, whose disease has been progressed to the multiple complication with a long-standing poor glycemic control as evident by raised serum creatinine level and low eGFR. He can be managed by a multidisciplinary approaches, including the regular glycemic control, as well proper monitor of blood pressure and lipid profile, regular health checkups and screening to prevent or detect the organ or organ-related complication, which may lead to disease progression. The patient should follow a very comfortable lifestyle, a protein-restricted diet, a salt-restricted diet, regular exercises along with the medication and good blood sugar level. These are the references which I have taken from PubMed.
You have presented well, but tell me one thing: what is uniqueness in your topic? Because in poster presentation and in oral presentation,
yes,
there is some uniqueness in the topic or case.
So I have mentioned that the patient is having multiple kind of complication even after not a good glycemic control over a long period of time, and he is still facing with so many type of complication, which is including microvascular and macrovascular as well.
Yeah, these all are the complications of uncontrolled diabetes or uncontrolled hyperglycemia. Okay, so topic should be.
So because
it's okay. So what is the use of urinary ACR?
Sorry, sir.
What is the role of or use of urinary ACR? You have told, na? Creatinine ratio.
You have mentioned, na?
Yes.
Investigation.
ACR.
ACR.
So that is 16.3 mg per dl.
Only 16. It is microalbumin. It will not be the range of microalbumin.
Yeah.
Yes.
So the disparity in this case is that you are showing that the patient's GFR is below 20.
Yes, sir.
And the patient is not having significant proteinuria.
Yes, sir.
So this is non-albuminuric CKD.
Yes, sir.
Most important peculiarities in your case is that this is non-albuminuric
CKD.
But the point is that your patient presented with a fever.
Yes, sir.
So whether it's a case of acute kidney injury, acute or chronic CKD, or it's a CKD, how you will distinguish? Because it might be a case of acute kidney injury.
Yes, sir.
Because your patient presented with a fever.
Yes, sir.
The patient sometimes may rise into the sepsis and the fever, sometimes pyelonephritis or any specific infection. And you have labeled this patient as a case of CKD.
Yes.
How you will distinguish?
So if the patient is presenting the complaint only for 5 days, like the fever is present just only for past 5 days, so sir, I forgot. Yes, sir. Yes, sir.
जान लीजिएगा।
No, sir. Yes, sir.
So you have tried to present a poster in the internship stage, so I appreciate it. So one thing I would like to ask, so you have told that GFR was 20. So can you tell me that what is the stage of CKD at the level of GFR 20? What will be the staging, CKD staging based upon GFR?
According to KIDGO classification, sir.
Yes, yes.
It can be G3.
G3.
Yes, sir.
And what is the latest classification of CKD? It is based upon only GFR or anything else?
No, sir. Serum creatinine level is also.
No. GFR and albuminuria both are included in the classification. And the latest classification also includes COUG. It is CGA classification, COUG, GFR and albuminuria.
Sir.
Okay.
No questions from my side. Really appreciate. Being an intern, I have never presented a poster when I was in college. It is appreciable.
Good.
Thank you. Good.
Thank you, sir.
To the judges, I am Dr. Yagya Srivastav, intern batch 2021 from RDJM Medical College. Today I present poster on the study Silent Epidemic Awareness and Barrier to Diabetes Care in Rural Area, a survey among subjects with diabetes in Bihar. Conducted under the guidance of Dr. Abhijit Kumar, Associate Professor in General Medicine, and Dr. Prachi Priya, Associate Professor, PSM and RDJM Medical College. Introduction. Diabetes mellitus is quietly advancing through Bihar's villages, a disease where awareness lags further behind diagnosis and diagnosis lags further behind care. The recently published ICMR India B study revealed an overall diabetes prevalence of 11.4% with rural prevalence of 8.9%. Poor education among rural subjects combined with financial burden makes them specially vulnerable to bad outcomes. Lack of awareness about self-management, insulin use and lifestyle modification is a major contributor. Patients often have to travel to towns for medicine and investigations, which lead to poor compliance and loss of follow-up. This makes awareness of timely, holistic diabetes management essential for improving quality of life in our rural population. Related literature. Existing literature gives us useful context through Bihar-specific data is limited. The ICMR India B study found a national diabetes prevalence of 11.4% with pre-diabetes at 15.3%, and Bihar's undiagnosed cases are drawn from this same pool. Bihar's recorded the lowest state-level diabetes prevalence at 4.3% among the 15 states surveyed and in ICMR India B, but the low prevalence does not necessarily mean low burden. It may simply reflect underdiagnosis. This is reinforced by the global burden of disease study, which ranked Bihar 30th out of 31st state for diet quality, physical activity and smoke exposure indicators among the poorest lifestyle risk profiles in the country. Taken together, this suggested Bihar likely has a large undiagnosed and undermanaged diabetic population, exactly the gap our study set out to explore. Understanding the necessity of the hour, this study was conducted with the following objectives in the mind. First, to assess awareness about diabetes symptoms, complications and management among rural diabetic patients, and second, to identify the barriers to diabetic care in this population. Methodology. We conducted this study in rural field practice area of our tertiary care hospital over a period of 2 months with a sample size of 100. One village, Amarak, with a census population of 6,514 was randomly selected by the lottery method. We included adults above 18 years with type 1 or type 2 diabetes and excluded the minors, the severely ill and those unwilling to participate. Data was entered in Microsoft Excel 2010 and analyzed using SPSS version 23. We calculated the percentages and frequencies and used the chi-square to determine association with p less than 0.05 considered statistically significant. Results. Looking at knowledge, only 52% of respondents knew about symptoms due to uncontrolled blood sugar, while 25% understood symptoms correctly and 36% were aware of hypoglycemia as a risk. For treatment practices, a majority, being 78%, relied on the allopathic treatment, of which only a smaller portion, that is 32%, used insulin, and a very few used Ayurvedic treatment or had no treatment at all. On barrier to care, our chi-square analysis showed statistically significant associations across the board. 75% reported low education levels, 83% reported difficulty in purchasing medicines, 88% reported non-availability of testing facilities, 78% reported non-availability of doctors. These figures highlight the structural and educational barriers, not just individual behavior, that are driving poor diabetes outcome in this rural population. Conclusion: the ICMR India B study reported that the ratio of undiagnosed to diagnosed diabetes is higher in rural areas compared to the urban areas. Our study reinforces this. It helped identify a clear lack of awareness about diabetes among our rural subjects. Going forward, we need to reach out to rural communities through mass contact programs, awareness drives, and screening camps. We also need to educate local pharmacists to help ensure better medication and compliance among the rural diabetes patient. Thank you.
Dr. Yagya, you have presented nicely, but the same thing is lacking in your presentation is novelty, but it's good. Two things I want to ask. What are the diagnostic criteria according to ADA for diabetes mellitus?
How do you diagnose diabetes?
So through screen test for fasting blood sugar, random blood sugar, and HbA1c tests.
There is a diagnostic criteria.
Yes, sir.
Because your topic was awareness, no?
Yes, sir.
Regarding diabetes mellitus in the
Yes, sir.
population.
Yes, sir.
So first you have to know how to diagnose the patient of diabetes.
Okay, sir.
So can you tell me the diagnostic criteria? Okay. The second thing I want to ask you that when a patient of diabetes mellitus come to you, the first and foremost and the basic thing is to aware the patient before going to pharmacotherapy. Okay?
Yes.
So how do you aware the patient before pharmacotherapy? कैसे आप उनको बताएंगे क्या करना है, कैसे करना है, कैसे रहना है, क्या खाना है? एक मोटा मोटी practical, in a practical approach, you are sitting in your OPD and a patient of diabetes mellitus came to you, कि madam, I have diagnosed recently with diabetes mellitus. So first you have to tell the patient and aware the patient about the diabetes mellitus and how to care your body, how to care your health.
Yes, sir.
कितना क्या करना है, कैसे करना है, क्या खाना है, क्या एक्टिविटी करना है.
Yes.
How you aware the patient?
So we'll explain the patient in their local language about daily. First we'll ask about what are the occupations, if it is sedentary or not. Then we'll inform the patient for everyday exercises.
For example, he said that I am a clerk and I have a sitting job. So what do you suggest?
So I'll suggest at least.
And he also said that I do nothing. I prepared for the duty from the morning and I go and sit on the table, and in the evening I come to home and eat the dinner and go to bed.
So we will advise the patient for 30 to 45 minutes daily walk.
Good.
And then we'll advise to keep the amount of food less. It is better to have less food in more quantity. Every 2 hours you can consume some little amount of food, and then we'll advise the patient to take less carbohydrates, avoid rice as much as possible, then take more protein and fiber diet, to include more protein and fiber in their diet.
In terms of protein, बोलेगा कि मैडम मैं क्या खाऊं, चिकन खाऊं, मटन खाऊं, सब में तो प्रोटीन ही है.
So we can.
Because your topic is awareness, that's why I'm asking. And it is the job of everyone, every healthcare personnel, to aware the patient regarding these basic things. Pharmacotherapy is the secondary.
Yes, sir.
Okay. तो वो पूछेगा कि मैडम मैं तो मटन रोज खा रहा हूँ, उसमें तो प्रोटीन रहता ही है।
नो सर, इट हैज़ फैट्स।
हाँ, तो आप क्या सजेस्ट करेंगे उसको?
सर पल्सेस वगैरह ज़्यादा
और?
सजेस्ट करेंगे सर। उसके अलावा
आपको 5-6 नाम गिनवाना पड़ेगा ना उसको बोलने के लिए, तब शांत होगा वो।
सर दाल एंड एग एंड विल सजेस्ट ग्रीन लीफी वेजिटेबल्स लाइक पालक एंड पनीर।
फिर वो बोलेगा कि मैडम भूख बहुत ज़्यादा लगता है, फिर क्या करें? आप बोलिए कम खाने के लिए, मेरा पेट तो भरता ही नहीं है।
सर हर 2-2 घंटे पे सर फ्रूट्स एडवाइस करेंगे सर। मतलब आप फ्रूट्स खाएं या कोई ड्राई फ्रूट्स वगैरह। ड्राई फ्रूट्स
से पेट नहीं भरेगा। There is a concept of low energy, high density foods. Having low calories, but they have high densities to fill the stomach, maintain the satiety. Fine. Our topic was about awareness.
Yes,
I have a very small basic question. Why do you want to aware the patient?
Sir, because Southeast Asia is one of the most मतलब सर यहाँ पे डायबिटीज़ के पेशेंट बहुत ज़्यादा है सर। मतलब बहुत बड़ा हब है एंड ऑल्सो सर कोमॉर्बिडिटीज़ एंड द कॉम्प्लिकेशंस आर वेरी मतलब बहुत ज़्यादा होता है सर कॉम्प्लिकेशंस ऑफ डायबिटीज़ सर। इवन small wound infections can cause gangrene.
So means the answer is like you don't want to only change the numbers. You are worried about the quality of life of the
Yes,
patient, which is going to occur with respect to control of diabetes and
Yes.
reducing the risk of micro and macrovascular complications.
Yes.
Simple. Fine. Nice.
So in your study, what was the exclusion criteria? किस तरह के पर्सन्स को आपने स्टडी में शामिल नहीं किया? जैसे कोई अगर ओबेस पर्सन है, कोई अल्कोहलिक है, स्मोकर है, तो ओबेस पर्सन्स को आपने स्टडी में शामिल किया या एक्सक्लूड किया?
सर
बिकॉज ओबेसिटी इटसेल्फ इज अ रिस्क फैक्टर फॉर डायबिटीज़। सो ऐसे पर्सन्स को क्या आपने स्टडी में इंक्लूड किया या एक्सक्लूड किया?
नहीं सर, इंक्लूड किया था जो ऑलरेडी डायग्नोस्ड थे मतलब डायबिटीज़ से, कि जिनका ऑलरेडी मतलब था कि टाइप 1 या टाइप 2 डायबिटीज़ में है सर, उन लोग को इंक्लूड किया था। और जो 18 के अबव थे उन लोग को इंक्लूड किया था सर।
Thank you. I really appreciate the same thing. Being an intern, it's hard and it's good also to present poster at this level. Great.
I'm present here. The topic of my poster, myself Dr. Ankita Rai, Junior Resident, IJMS Patna. The topic of my poster is pain without pus, that is diabetic myonecrosis, which is also known as diabetic muscle infarction. The case was there is a female patient of 42-year-old having 17-year history of diabetes mellitus. She came with swelling and severe pain in right thigh, which is acute in onset and gradually progressive over 5 days. There was no skin discoloration and there was no skin discoloration on examination. There is severe pain and on local examination there is tenderness, swelling over the anterior aspect of the right thigh with local tenderness and warmth area is present. On investigations, we have there was the main DDs are like cellulitis and that we think in patient of diabetes as a first case. There is we think about cellulitis, so we but there is no increase in there is no fever. And on examination we have done the Doppler, but Doppler studies are normal. On ultrasound there is ill-defined patchy areas, and in ultrasound there is no presence of abscess or pus. On MRI there is muscle edema and patchy non-enhancing areas which suggest muscle infarction. Overall there is we can't think about the typical diabetes complication, that is cellulitis or any compartment syndrome or myositis.
So we finally came to the diagnosis of diabetic myonecrosis, which is a very rare complication of type 2 diabetes. We managed the patient with glycemic control, a strict glycemic control, analgesics, and antiplatelet therapy. Finally, this is a rare case of diabetic myonecrosis, which is a very rare complication of type 2 diabetes mellitus, and the main DDs are necrotizing soft tissue infection, pyomyositis, and cellulitis, DVT. Yes.
Is there any role of biopsy in this case? Whether biopsy is mandatory or not?
No, sir.
Why? Biopsy is harmful or beneficial in this case?
Sir, harmful.
Why? It may cause delayed wound healing.
Yes.
Okay. You have taken care of all the small parts of the case that is there. If I would ask what is the investigation of choice, then what will be your answer?
Sir, MRI.
And is there any role of CPK or CK, like creatine kinase?
Sir, CPK to exclude like polymyositis or.
So will it rise in this case because
Sir, can be mildly elevated, but all of them.
Whenever there is some involvement of muscles,
Yeah.
you know, there will be rise of CPK.
Yes,
Then muscles involved, there is myonecrosis is ongoing. Then we expect a rise in CK. Then why there is a mild rise?
Sir, because there is muscle infarction involved in this. CPK will rise if there is.
For example, if you are considering myositis as a
There is no
differentiate
inflammation.
So the inflammation in myositis, when you compare and the inflammation here, this inflammation is very much localized.
Yeah.
So the chances of rising of CPK is actually not that much when we compare it with two other muscle disorders.
How many cases are reported till now on this topic?
Sir, less than 200 or approximately.
Less than 200 is not a small. Have you gone through that article's previous case report?
Yeah, yes, sir.
So how much it is rare? आप गई हैं कि नहीं गई हैं? क्योंकि 200 अगर केस है तो it is a good number.
Sir, compared to other complications, it is.
Okay. How do you treated this case?
Yes.
How do you treated this case?
Sir, with strict glycemic control, analgesics, and antiplatelet therapy is given in some cases.
Is there any role of antibiotics?
No, sir.
It can be used when there is superated bacterial infection, superimposed infection of the surface.
Whether patient came back in your OPD after discharge?
Yes, sir.
What was the status of the patient?
Sir, she came after 2 weeks, and there is significant improvement is there.
So what do you mean by significant improvement?
Sir, the swelling has reduced, and pain is also decreased.
I think it is better to take the snap of the improved part and display there. That will be the. This will make a comparison how you have started the treatment or how it is beneficial for the patient, and how much time it is get treated or improved. Okay. Your topic is very good.
What were your other DDs and how did you rule them out one by one and came to this final diagnosis?
So the first DD is cellulitis. In cellulitis, there is fever, and
Only fever.
no, sir, fever plus redness over the wound. There is no redness over the wound in cellulitis. There is no skin changes, or plus there in ultrasound, sir, there is pus or abscess. There is no crepitus.
Any other differential diagnosis?
Sir, DVT is the second, which we rule out from Doppler. Thank you, sir.
Resident from Emergency Medicine, IGIMS Patna. I am here presenting a atypical case of a patient with a diabetes mellitus. A 52-year-old male presented in ED with a 2-day history of progressive nausea, fatigue, vague abdominal pain, shortness of breath, poor oral intake, associated with the comorbidities, type 2 diabetes mellitus from 12 year and was on empagliflozin 25 mg daily and metformin 1000 mg, and is also a known case of ischemic heart disease from last 3 years. On physical examination, patient was mildly dehydrated, tachypneic with deep respiration, which can call as a Kussmaul's breathing, soft abdomen with no guarding. On emergency evaluation, BP was 110/70 mmHg, pulse rate of 112 beats per minute, respiratory rate of 12 per minute, SpO2 of 96% on room air, GCS was 15 out of 15, temperature was afebrile, random blood sugar was 168 mg per deciliter. The provisional working diagnosis of diabetic ketoacidosis, acute coronary syndrome, acute gastroenteritis or sepsis with UTI. The initial investigation that was done was ABG, ECG and POCUS, and also TROP-T. On initial ABG, pH of 7.1, serum ketones of 4.2, anion gap of 24, bicarbonate level is 12, urine ketones was present, glucosuria present, TROP-T negative, ECG shows sinus tachycardia and POCUS was normal. So, the final diagnostic approach in a ED with initial arterial blood gas through which we access the pH and bicarbonate, serum electrolytes, calculating the anion gap and serum ketones, especially beta hydroxybutyrate, which is a gold standard, and the level was more than 3 millimoles per liter, supports the diagnosis of euglycemic diabetic ketoacidosis. So what is the euglycemic diabetic ketoacidosis? Euglycemic diabetic ketoacidosis is a metabolic acidosis with elevated anion gap, ketonuria, and blood glucose typically less than 200 mg per deciliter. Distinguished it from the classical DKA, where the blood glucose level is more than 250 mg per deciliter. First described in 1973, it was considered rare, having 2.6 to 3.2% of DKA cases. The current rate has increased widespread due to the widespread use of SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin for type 2 diabetes mellitus, heart failure, and CKD has led to the significant increase in euglycemic diabetic ketoacidosis cases. Among the SGLT2 inhibitors, associated DKA cases is 35 to 66% as euglycemic DKA. The proposed staging system for diagnosis and monitoring are stage 0 or 1 is ketone negative or low, anion gap normal, at risk stage we call it. Stage 2 is ketones present, anion gap normal, impending euglycemic decay. Stage 3, which we call as a full-blown UDKA, having a ketones present and anion gap more than 15. The pathophysiology involved in this euglycemic DKA is mainly multifactorial, which is accelerated by SGLT2 inhibitors. SGLT2 inhibitors promote the glucosuria, renal glucose excretion, lowering the blood glucose level. Second is a starvation physiology, in which triggers by the endless fasting lead to the insulin deficiency, elevated counter-regulatory hormones like glucagon or catecholamines, enhanced ketogenesis. Glucagon elevation, volume depletion from SGLT2 inhibitor further stimulates the lipolysis and ketone production. The result is that the body produces a keto acids which simultaneously losing glucose in urine, leading to the acidosis without severe hyperglycemia. The risk factors involved are the medications, use of SGLT2 inhibitors. The clinical scenarios are reduced oral intake or fasting, acute illness like infections or other serious infections, gastroenteritis with vomiting, perioperative period, low carbohydrate or ketogenic diets, excessive alcohol intake. Patient factors that are responsible are type 1 diabetes mellitus, latent autoimmune diabetes, low BMI, pregnancy. The clinical presentation and diagnostic pitfalls are symptoms include nausea, vomiting, malaise, abdominal pain, tachypnea. The critical difference, absence of profound hyperglycemia means polyuria or polydipsia are often absent. Pitfall, a normal or mildly elevated point of care glucose may prematurely rule out a metabolic emergency leading to a dangerous diagnostic delay and worse outcome. The management algorithm is similar to the diabetic ketoacidosis, but the crucial nuances to prevent the relapse. First is to stop the SGLT2 inhibitors, IV fluid, isotonic saline for the volume resuscitation, IV insulin infusion at a fixed rate of 0.05 to 1 unit per kg per hour. Goal is to correct the anion gap, not just to lower the glucose. Dextrose infusion is a critical state. Start D10 early when the blood glucose is less than 200 milligram per deciliter to prevent a hypoglycemia with continuing insulin to clear the ketone. Serial monitoring of via VBG, electrolyte, anion gap, ketones every 2 to 4 hours. Transition to the subcutaneous insulin. Start a basal insulin 2 to 4 hours before stopping the insulin drip. Dose based on the weight, 0.3 units per kg per day or the last 6 to 8 hour insulin requirement. Do not stop the insulin drip prematurely. Risk of relapse is high. Discharge planning should be the patient education is vital. Discuss the sick day rules, ketone monitoring, cautious reinitiation of SGLT2 inhibition only after discussion with the endocrinologist. This is a reference taken from the BMG Open Journal where the same case has been discussed of euglycemic diabetic ketoacidosis in the era of SGLT2 inhibitors. The take-home message from my presentation is euglycemic diabetic ketoacidosis is an emerging dangerous complication linked to SGLT2 inhibitors. It is a diagnostic trap in an ED due to the lack of significant hyperglycemia. The management requires a vigilance, early ketone testing, concurrent dextrose with insulin, and prolonged careful transition to the subcutaneous therapy to prevent the relapse. Awareness and education for both healthcare provider and the patients are key to prevent and timely treatment. Thank you. These are the references. Thank you.
You have described the GCS score E3, V4, M5.
Yes,
So why there is a this is not a cause of CNS?
Sir, I have described the GCS as E3, V4, M5. Patient is not opening the eye voluntarily. E should be spontaneous eye opening is E4, and patient is not. Maybe due to the, sir, I have mentioned the patient has a vague abdominal pain. Maybe he has closed his eye due to that cause also. So if we have assessed the GCS and patient having a E3.
I think this score can be happen in this case when it is a case of diabetic ketotic coma.
Sir, can be, we call it as coma, but the other factors of GCS like vocal and motor, which is full. Like, sir, I have also mentioned that GCS have M4 or vocal is 4. So for calling it a coma, I think, sir, that not agree with the vocal 4 or M5.
Have you ruled out the CNS cause?
Sir, on the initial as an emergency medicine, I haven't done for the CT or other, but he was following my vocal commands. Vocal was 4, so I thought he is.
It may happen in some CNS cases. So can you examine the planter?
Sir, I have examined the planters and planter was perfectly normal in this patient. Sorry, sir, I haven't mentioned it here.
Second thing, in your opinion, when should be the SGLT2 inhibitors should be initiated? You have taken the consultation of endocrinologist, but being a physician, when you suggest to start the SGLT2 inhibitors in this patient, especially?
Sir, I have clearly switched for transition to the subcutaneous insulin. My focus was on, as a patient was non-compliant to the therapy. I'm saying non-compliant to the therapy because SGLT2 inhibitor is leading to the euglycemic diabetic ketoacidosis in the patient. Patient may check the blood sugar level and patient having the normal blood sugar level, but patient may have the ketoacidosis. So I will suggest for insulin therapy rather than SGLT2 inhibitors. If there is other indications for SGLT2 inhibitors, like maybe patient have a cardiovascular risk, I will advise for the SGLT2 inhibitors considering proper checkup for the ketone bodies regularly for the patients.
So if there is a cardiac risk or kidney risk, you can only start the SGLT2 inhibitors in this patient.
Yes.
Otherwise, you cannot afford to take this medicine in that patient. Okay.
Any other test that you can think to confirm the diagnosis of euglycemic ketoacidosis?
Sir, I have mentioned here for the ABG, serum ketone bodies. These two tests I have mentioned here, but other tests I will suggest for, like there are other ketones also formed apart from the beta hydroxybutyrate, like acetone, which is excreted through breath, or acetoacetate forms which are eliminated further. So I'll go for.
What will be the cutoff for beta hydroxybutyrate to tag it as a?
Sir, more than 3 units.
And for example, if you have done urine ketones, 2+, so the criteria is?
Sir, urine for ketone bodies is 2+ or?
2 or 2+, right? Will you do ketone bodies further when the patient is admitted or not?
Sir, we will, basically there is no need for the serial ketone bodies monitoring in this patient.
Why?
First is, sir, we have confirmed our diagnosis of diabetic ketoacidosis.
Right.
We have to treat it, and sending again a ketone bodies is of no use.
Sometimes at many places you will see now people are repeating urine ketones. Sir, abhi bhi DK mein hai. Abhi bhi still, then why?
Delayed metabolic response के कारण वो persistently हमारा ketone bodies present ही रहेगा unless and until it takes time to get normal.
Then how to show the patient that he is improving with reports, not clinically? Attendant will be asking कि सर रिपोर्ट में तो अभी भी पॉजिटिव आ रहा है पहले दिन से. Beta hydroxybutyrate, if it is available, you can go for serial that reduction of all. So that will help to justify your answer. Thanks.
If a diabetic patient is on SGLT2 inhibitor and any elective surgery is planned, then when will you stop the drug?
Sir, as the anesthesia, during UG days we have learned that we don't stop the oral hypoglycemic agent before 24 hours of the surgery and switching it to the insulin.
In case of SGLT2 inhibitor, I have SGLT2 inhibitor. I have particularly focused on that drug.
Many people don't stop it.
Yes, because it may precipitate euglycemic decay at the perioperative period. So how many days before you will stop this drug?
Sir, जैसे कि मैंने एक 6-day rules का डाला था. 6-day
Yes,
rules में जो हम लोग पढ़ते हैं कि if there is any stressful conditions, we should stop.
A specific time period is mentioned for this drug. So,
मेरा सर्जरी 2 दिन बाद प्लान है, 4 दिन बाद प्लान है, 1 हफ्ते बाद प्लान है.
at least 3 to 4 days before this drug should be stopped. Okay, at least 3 to 4 days before. Okay, and you have told 6-day rules. So apart from SGLT2 inhibitors, what are the other drugs in which 6-day rules should be followed apart from SGLT2 inhibitors?
Sir, there is
In a case of diabetic patient.
Sir, in a case of diabetic patients, any drug leading to the AKI or provoking other symptoms.
Give some examples.
Sir, metformin.
Yes, metformin. Any other drug? Any other drug?
Like dapagliflozin, SGLT2s to all of it, baguanides we stops or pioglitazones we stop before.
AC inhibitor and ARBs. It should also be stopped in case of CD. Yes, thank you.
What about potassium management in this case? When will you manage the potassium beforehand, or you will just give fluids only and you will won't manage potassium?
Sir, for potassium management, here is a two thing. Like we give potassiums are managed by the insulin. Insulin takes the potassium into the cells. Here we are giving the insulin as a fixed rate. This is the goal of insulin is only to close the anion gap and treat the potassium level of the patient. Here is not for the glycemic control, as patient is already euglycemic. So here we are going through the insulin therapy for that only.
Is there any potassium level for which you will replenish the potassium first, and then after that you will start the insulin?
Sir, here the management is as same as a DKA. First we have to treat the acidosis of the patients, and then further we go for the potassium levels treatment of the patient.
What are the indications of bicarbonate supplementation in this patient?
Sir, bicarbonate supplementations of this patient depends the patient having other conditions leading to pH. Basically, bicarbonate role is to buffer the pH of the body. So here we have C for the acidosis. If it is responsive to the initial therapy, we should not go for the bicarbonate therapy.
When you suggest, क्योंकि जैसे हम लोग राउंड करते हैं तो पेशेंट जो है ना, ये जो JR होते हैं वो घबरा जाते हैं कि सर इतना जो है बाइकार्बोनेट इसका बहुत लो हो गया है, तो दे ही देते हैं इसको.
सर जनरली हम DKA में बाइकार्बोनेट से ट्रीटमेंट नहीं करते हैं.
दिस इज द फर्स्ट लाइन. ओके.
यस सर, DKA में हम बाइकार्बोनेट से ट्रीटमेंट नहीं करते हैं, क्योंकि बाइकार्बोनेट जो वहाँ पे है वो बफर कर रहा है हमारे ब्लड पीएच को मेंटेन करने के लिए. तो हमको वहाँ पे बाइकार्बोनेट के लेवल पे पैनिक नहीं करना है. हमको हम बाइकार्बोनेट ट्रीट नहीं कर रहे हैं, हम DKA ट्रीट कर रहे हैं. तो वी शुड फोकस ऑन द DKA फर्स्ट.
Yeah, this is the golden line. कि never focus on bicarbonate infusion or supplementation first, but when we should suggest to give the bicarbonate.
Sir, we will initiate the bicarbonate.
Some indications are given. There you have to give the bicarbonate.
Sir, जैसे कि हम ABG एनालिसिस पे गए और हमारा ABG एसिडिक पे रेंज पे है. हमारा जो CO2 है वो भी कंपनसेट कर चुका है, बाइकार्बोनेट भी कंपनसेटरी रेंज पे. अपार्ट फ्रॉम द कंपनसेशंस द पेशेंट्स कंडीशन इज नॉट इम्प्रूव्ड.
आई एम आस्किंग अ डायरेक्ट क्वेश्चन.
सर डाटा याद
नहीं. You have to go for the severe acidosis.
Yes sir.
If pH is
6.9 or 6.99.
Below 6.2.
Oh, 6.2.
Okay.
6.9 is
6.95. Okay. 6.9. Yeah. और कोई है? Okay, thank you.
Thank you, sir.
Seeing a case about a young male patient. So the topic is headache to hemiparesis and a seizure, that is unmasking cerebral venous sinus thrombosis. So imagine it's your shift. A young male, 17-year-old boy, comes in with a headache for 2 days, which was sudden in onset, severe and diffuse, and there was no trauma or fever. So what could have been the top differentials? It could have been a primary headache disorder, or it could be press, or it could be some SAH-like condition, or other type of a stroke could be there. So the story evolves further. There was sudden loss of consciousness. Then there was GTCS, which was associated with a prolonging of eyes and involuntary urination, and there was post-ictal confusion. It happened on the 3rd day of the start of headaches. Later on the same day, that is the 3rd day, patient had 2 more GTCS episodes, vomiting, that was 4 episodes, non-bilious and non-projectile. and there was right arm weakness and facial asymmetry along with slurred speech. Patient went to some outside hospital, but later he was referred to ER at AIMS Patna. So there was negative history for trauma, fever, ENT bleed, ear discharge, bleeding disorders, or recurrent oral ulcers and rashes. Past medical and surgical history, there was no TB contact, no significant past medical or surgical history. Patient had addictions of alcohol and ganja for around 1 year. So on arrival in the ER, the vitals were almost normal and patient was afebrile. On primary survey, the airway was patent, breathing spontaneously, no signs of hypoperfusion were there in circulation. AVPU score, patient was verbal responsive and GCS was around 12. There were no external injuries. On secondary survey, there was headache, GTCS, vomiting and focal weakness, which were the presenting symptoms. There was no allergies, there was no medication, but addictions of alcohol and ganja intake was present. Then there was no significant past medical history. Last meal was dinner before coming to the ER, the previous day of presentation, and then he presented to ER on 27th. On systemic examination, so GCS was E4, V2, M6. There was weakness in the right upper limb, and the power was 2/5 in all 3 joints of right upper limb, and the rest limbs had all joints power 5/5. There was right plantar extensor, left first flexor. Facial deviation was towards the left side, and there was no sensory deficit. Chest examination, bilateral air entry was present, normal vesicular breath sounds were present. Circulatory system examination was also normal. Per abdomen it was soft, non-tender, and bowel sounds were present. On general examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. So initial CT brain was ordered owing to the presentation of patient which was headache, seizure, vomiting. So the observation on initial CT were multiple hyperdense cortical and subcortical lesions were present. Multifocal hemorrhagic appearance was present, and there was these presentations, hemorrhagic appearances were atypical for any primary hypertensive hemorrhage. So further radiology correlation was advised. So you can look on the pointer, it is showing the cortical and subcortical, that is cortical bleed. This is also cortical and subcortical bleeds are present. So why this case seems different to us? There was a young patient, he had headache, then seizures and multifocal hemorrhages on the CT. So due to the suspicion, due to age demographic, a consideration of cerebral venous sinus thrombosis was made. And so the investigation of choice, that is MRI brain and MR venography was performed for this patient. On MR venography, there was superior sagittal sinus thrombosis and right transverse sinus thrombosis, and diagnosis of CVST was established for this patient. So this is for reference a normal MR venography, and this is the patient's MR venography. You can clearly see that there are cutoff signs on this superior sagittal sinus area, and then on the right sinus area also, right venous sinus also. So MRI brain plane, it showed the same lesions as we had seen on the CT, which were multiple hemorrhagic venous infarctions. But again, there is a question, why would there be a right-sided thrombus which had causes the left-sided hemorrhagic infarcts? So the culprit was mainly the back pressure venous congestion, which had led to the hemorrhages on the left side, while the thrombus was on the right side. So venous infarcts are unique, and they cross the arterial territories, and they demonstrate more pronounced edema on the MRI. On the sagittal and coronal MRI, we can look at the extent of lesion of thrombus in the patient. So there was emergency medicine dilemma. There was intracranial hemorrhage also, and there was intracranial thrombosis also. So should we anticoagulate this patient? So we had also sent some blood workup, so which had also come almost normal, and they were all mostly within the normal range, and PTINR was also in the limit, and platelets were normal. So the management was started in ER. The first aim was seizure control. So initially levetiracetam was loaded for the patient, and the need for sodium valproate was also required because there were seizures were not controlled on levetiracetam. Then for treating the cause, so the patient was loaded with injection enoxaparin 60 mg subcutaneous stat followed by weight-based dosing of 40 mg BD for 5 days. Later, the patient was switched on oral apixaban. So further exploration, like what made the patient go into CVST. So procoagulation, prothrombotic states needed evaluation. The patient was looked on for any dehydration signs. Homocysteine levels were sent. Protein C and protein S levels were also sent. So outcomes and learning, like right upper limb power improved. The outcome for the patient was the right upper limb power had improved from 2/5 to 5/5 on the 5th day of the treatment. And the headache, seizure and focal, whenever there is a young patient with headache, seizure, focal deficit, we should always think about the cerebral venous sinus thrombosis. And we should note here that the hemorrhage distracted us, but thrombosis was the main diagnosis. So that's it.
So, what are the causes of young onset CVA?
Young onset CVA. So there could be CVA as in like a broad diagnosis.
Yeah.
So mostly it could be some aneurysm could be there, which was there, or it could there could be prothrombotic states in a patient, which could be due to the coagulation factor disorders. It could be the deficiency of protein C and S, like so.
So in this particular case, what was the etiology found?
So we had sent workup for homocysteine C and S, which came to be deficient in the patient on follow-up.
So what is the strategy of the treatment in your case?
In our case, like after the ER management was done, patient had improved his power in his right limb, and facial asymmetry was residual, which improved over 2 to 3 weeks when patient came on follow-up. And once the protein C and S levels came, and homocysteine levels were also sent, which were normal. So the patient was started on vitamin B12 and folic acid supplementations, and yes.
What is your treatment plan from anti-epileptic in your case?
Okay, so the patient did not at the time of presentation the seizures were not there, so the status epilepticus phase had already gone. So we had loaded the patient with levetiracetam, but then again
in the long-term period, when you decide to take off the anti-epileptic,
sir, if the patient is
what will be the duration, whether you take off the anti-epileptic or not?
Okay, so if any patient is on multiple drugs, so if there is seizure-free period of at least 2 years, then we can think of reducing the dose, and we will check whether the patient is tolerating that reduced dose of anti-epileptics on follow-ups. Then we can slowly taper off one of the drugs, and then we will go for the other drug.
Whether is this guideline work for all CNS cases or in some cases particular?
So one case not pertaining to especially this case, but I think since the etiology was addressed in this case, so we could think of
whether etiology is not found or whether the patients are on continued anti-epileptic.
So primary seizure disorder के लिए mostly हम वो वाली strategy use करते हैं.
What is non-convulsive status epilepticus? Have you heard this term? Non-convulsive status epilepticus.
Sir, non-convulsive. Sir.
So in this condition, the seizure-like activity is continuously ongoing without GTCS-like symptoms, and there is persistent fluctuating mental status.
Only
sensorium will be.
Hmm. Sensorium will be altered
there
and
would not be
GTCS-like symptoms will not be there. But if you do EEG, then continuous seizure-like activity will be present in this condition, non-convulsive status epilepticus. Suppose you are working in a remote area where MRI facility is not available, only CT is available. Then what other differential diagnosis will you suspect in this case? And how will you proceed? Suppose MRI is not available, you are working in a district hospital, and CT brain is done, and these findings are present, then what other differential diagnosis will you suspect?
Sir, CT brain was suggestive of atypical bleeding areas. So
Okay.
this was not in line of arterial territories. First, it was a clue. So then we could also, if the CT facility is available for angiography, we could go for that also.
Okay.
Mainly that, and other differentials like I had discussed, it could be press or primary headache disorder, but again they won't present with bleeding.
Yes.
So these were, whenever there is atypical areas of bleeding in any patient, we should always think of CVST, especially because in young age demographic, the prevalence of stroke due to CVST is around 40%, while all over in whole age groups, the burden is very low, as low as 2% only.
Whether neck rigidity was present in this case or not? No.
Neck rigidity was not present.
Sometimes in case of neurocysticercosis, there are also multiple lesions looking like this in this case. If lesions are large, then?
Yes. Sir, there would be ring enhancing.
Ring enhancing, yes.
There will be hemorrhage sometimes in thrombosis also.
Yes.
Will you use anticoagulation or not in case of sinus thrombosis?
Sir, there was a hemorrhage with thrombosis, so
so
we had used.
Sir, can you give a comment on this? Like,
Sir,
सब लोग बोलेगा hemorrhage हो गया,
yes,
anticoagulation.
So that was the dilemma we also faced. So in case of arterial thrombi, as we usually encounter, so there is a talk about the golden hour. But for venous thrombosis, we don't talk about the golden hour because even delayed thrombolysis can give us clinically beneficial results for the patient. So, so there is the infarct does not set in so early in case of venous thrombi. So we should
go for
thrombolysis.
Then when you will think of low molecular weight heparin or unfractioned heparin?
Sir, it was a young patient. We thought that kidney might not be that affected.
Like renal compromise. Other than that,
renal compromise. Other than that,
it's a basic. Maybe it's not related to this, but it's just the use of unfractioned heparin and low molecular weight heparin. UFH is short acting, so
sir,
if you want, if this high risk of bleeding and all, then we can stop. And then the things can be managed easily.
Yes, sir. We have antidotes also.
Yeah. ठीक है. Thank you.
Okay, sir.
Yeah, your presentation was good. Your case was good. Good. Thank you. The next.
Everyone, I am Dr. Aparna Ramjan, junior resident from the Department of Emergency Medicine, AIIMS Patna. My case is when diabetes strikes overnight, fulminant type 1 diabetes mellitus presenting as severe diabetic ketoacidosis in the postpartum period. So my patient is a 20-year-old patient who presented to us on post-op day 5 after a normal vaginal delivery. She was a primi gravida with no history of gestational diabetes mellitus, and she also did not have any family history of diabetes. The presenting complaint, that is, she presented to us on post-op day 5 with a 3-day history of vomiting, which was non-bilious, non-projectile, around 5 episodes per day, abdominal pain, which was right-sided, it was radiating to the shoulder and back, and also loose stools, which was non-foul smelling and non-blood tinged. The negative history was she did not have any history of gestational diabetes during pregnancy. There was no history of similar episodes in the past, and there was no significant family history of diabetes mellitus also. So the initial vitals, when the patient presented to us in the emergency, the pulse rate was 142 beats per minute. The blood pressure was 76/44 millimeters of mercury, giving a shock index of around 1.9. The respiratory rate was 34 per minute. SpO2 was 98% under room air, and her RBS was 550 milligram per deciliter. She was afebrile to touch. The general examination, she was drowsy and afebrile at presentation. There was clinical evidence of dehydration, including dry tongue. The relevant examination findings, abdominal examination revealed diffuse abdominal tenderness with guarding. Rest of the systems were within normal limits. So I have included only the relevant laboratory parameters in my case. The initial ABG at presentation showed a pH of 6.711. The bicarbonate level was 3 millimoles per liter. Lactate levels was 5.8 millimoles per liter. This is suggestive of a high anion gap metabolic acidosis with a pH of 6.71 and an anion gap of 31. The rest of the metabolic and pancreatic panels that when we investigated, it showed her urine ketones were 4+, that is, it was very high. The urine glucose was also around more than 1000 milligram per deciliter. Because of her typical symptom of abdominal pain, which was radiating to back, with a suspicion of pancreatitis, we also sent the amylase and lipase levels, which were well above 3 to 4 times of the normal range. The renal and liver function were within normal range, and just with a suspicion of pancreatitis, we also got an ultrasound done. Ultrasound did not reveal any pancreatic pathology. Further to confirm, we got a CCT whole abdomen also done. That also did not reveal any pancreatic pathology. So further, the key diagnostic clues for the confirmation of this case were, we sent an HbA1c level which came out to be around 7.8, which was near normal, and it was pretty discordant with the severity of the illness with which she presented. We also sent the islet cell antibodies, thinking whether she has come with us with type 1 diabetes mellitus or not, and that was also negative, which actually argues with the classical type 1 diabetes mellitus. We also sent a fasting C-peptide level which came out to be very, very low. It was 0.035 nanogram per ml. Actually, the normal level of fasting C-peptide level is 0.5 to 2 nanogram per ml. If at all we are expecting the patient to present with type 1 diabetes mellitus also, the range is around 0.2 to 0.5 nanogram per ml. But in this case, we can see it is so low. It is 0.035 nanogram per ml. So this is again suggestive of a near total loss of beta cell function. For the treatment and hospital course, we resuscitated the patient like any patient of diabetic ketoacidosis with IV normal saline at 150 ml per hour for volume replacement and shock correction. We also started her on insulin infusion at her initial bolus of 0.1 units per kg, followed by 0.1 units per hour infusion, which was gradually titrated according to her glucose levels. Gradually, her ketoacidosis resolved within 48 hours of initiating the treatment, and she was gradually shifted to the subcutaneous basal bolus insulin once stabilized. The patient actually achieved a very good glycemic control. Her sugars ranged between 110 and 180 milligram per deciliter at the time of discharge, and she was discharged on the insulin regimen of 12 units of regular insulin 3 times a day before meals and 14 units of insulin glargine once daily at bedtime. So now coming to the case, what is fulminant type 1 diabetes mellitus? It is an uncommon aggressive subtype of type 1 diabetes mellitus which is marked by sudden near total destruction of pancreatic beta cells. It was initially characterized in the early 30s and it evolves over days rather than months. So the very characteristic features of fulminant type 1 diabetes are its abrupt onset, that is life-threatening decay can develop within about a week of the first hyperglycemic symptom. Mostly the patient won't even be aware of their hyperglycemic symptom. Sometimes they land up to us in the ER straight with decay. Then the deceptive HbA1c, that is near normal or only mildly elevated HbA1c because hyperglycemia was too recent to be reflected in the HbA1c levels. Autoantibodies will be negative, that is unlike the classical autoimmune type 1 diabetes mellitus, the islet cell antibodies are usually undetectable. And also prodromal symptoms like flu-like or gastrointestinal symptoms often precede the metabolic crisis. Just like in our patient, she had some symptoms of vomiting, loose stools and abdominal pain. So the epidemiology, initially it was described in the East Asia and initially it was studied in the Japanese cohorts. And the high risk population most studied are 3 categories, that is the pregnant and the postpartum females, drug-induced hypersensitivity syndrome and patients on immune checkpoint inhibitors. Coming to the pathogenesis, the exact mechanism remains incompletely understood even now, but the current evidence points to a genetic predisposition triggered by an environmental insult. So mostly the patient will have a genetic susceptibility like the HLA DRB145, DQB141 haplotype is most consistently reported, and along with that the patient will have some environmental trigger, mostly some viral infection, leading on to hyperacute beta cell destruction which will cause near total irreversible loss of insulin secretion within days. So the diagnostic criteria for fulminant type 1 diabetes necessitates fulfilling all these 3, that is rapid ketosis, that is the patient will present mostly in decay or diabetic ketosis within approximately 7 days of onset of the hyperglycemic symptoms. The second one is a disproportionate glucose HbA1c gap. That is, the plasma glucose levels will be more than or equal to 288 milligram per deciliter with an HbA1c of less than 8.7% at presentation. And the third criteria that the patient will fulfill is the near absent C-peptide levels. That is, the fasting serum C-peptide levels of less than 0.3 nanogram per ml or less than 0.5 nanogram per ml post-glucagon or meal, or urinary C-peptide level of less than 10 micrograms per day. Along with that, there will be some supporting diagnostic features also. That is, the three are necessary for the diagnosis of the fulminant type 1 diabetes. Along with that, some of these might be present. Like islet autoantibodies are generally undetectable. They might have a short prodrome. Elevated pancreatic enzymes are seen in up to 98% of the cases reported with fulminant type 1 diabetes. Flu-like or GI prodrome may be seen in approximately 70% of patients. Peripartum occurrence as seen in our case, and HLA association. So how do we differentiate between fulminant type 1 diabetes and classic autoimmune type 1 diabetes? The onset of fulminant type 1 diabetes usually happens within days. As I told, the patient might not even be aware. Classical will give a time of around weeks to months and sometimes even years. HbA1c at presentation in fulminant type 1 diabetes is near normal, whereas in classical it is usually markedly elevated. C-peptide level is nearly absent in fulminant type 1 diabetes, indicating near total beta cell destruction, whereas it will be only reduced in classical autoimmune diabetes mellitus. Islet cell autoantibodies are usually positive in classical autoimmune diabetes, but in fulminant type 1 diabetes, it is typically negative. And pancreatic enzymes, it is elevated in most of the cases. As I told, around 98% cases of fulminant type 1 diabetes, but that is usually in the normal range in classical autoimmune type 1 diabetes. And there might be some prodromal symptoms which we expect in fulminant type 1 diabetes. The spectrum of diabetic ketoacidosis, as we know, classical decay, euglycemic, fulminant, and mixed decay. So in this case, what were the other DDs that I considered? We considered classical autoimmune type 1 diabetes, but it was ruled out because of the abrupt onset, the relatively low HbA1c, the negative islet cell autoantibodies, and profound C-peptide reduction. The second one that we considered on presentation was acute pancreatitis-induced hyperglycemia, because we had elevated amylase lipase levels also, but later the USG as well as the CECT ruled out the pancreatitis for us. Next, also stress-induced hyperglycemia, but that was excluded by the presence of severe ketoacidosis together with marked near-total insulin deficiency. So, pregnancy and postpartum period are considered high-risk windows for fulminant type 1 diabetes. Actually, among the type 1 diabetes mellitus that presents on presentation, only 1 to 3% is constituted by fulminant type 1 diabetes. That is the novelty of this case. It's pretty rare. And among that also, the reported cases of fulminant type 1 diabetes in pregnancy and postpartum period are very, very few. These were the two studies that I could find out by Kubola et al. And Lane and Oxman. So why the postpartum period is diagnostically tricky is because vomiting, abdominal pain and fatigue in the recently delivered woman are easily attributable to obstetric or other gastrointestinal causes. A metabolic emergency like fulminant type 1 diabetes can be missed and profound decompensation has already occurred. Why this case has fulfilled, I already told. Management principles and diagnosis, acute management, there is no difference. It is identical to any other cause of decay. Diagnosis does not change the management. We will give aggressive IV fluid management, insulin therapy and correction of the electrolytes. But the importance comes in the long-term implications. Because in these patients there is near complete beta cell destruction, means the patient will be permanently dependent on insulin lifelong. There is no residual insulin reserve unlike many classical type 1 diabetes mellitus patients. Early intensive insulin therapy and structured diabetes education has to be given, and long-term endocrinology follow-up is essential in these patients. So the key clinical takeaways in this case is discordance is the clue, and rest of this I have already described. Thank you.
Yeah, very good case and very good topic.
What are the causes of near total beta cell destruction in your patient?
Sir, that is what. Actually, fulminant type 1 diabetes, maybe the patient already had an HLA association. Actually, we could not get the genetic testing done because of its inavailability here. But maybe the patient already had an HLA association. Along with that, she had some viral trigger also during the postpartum period. As it is, the postpartum period is considered a high risk factor for fulminant type 1 diabetes mellitus. Actually, how we could prove the near destruction is because of the extremely low levels of C-peptide levels.
Yeah, these are the two main things you have explained, the viral infections and genetic susceptibility. So whether there is any clue for viral infection in your patient?
Sir, in this patient, we don't, as it is, have a proof for the viral. Maybe she had some prodromal symptoms. We don't know. Maybe it could be attributable to viral infections. But surely the clue to the viral infection could not be established.
So as you told that this beta cell destruction, inflammation, but there is no pancreatitis. So is there any role of steroid or immunotherapy?
No, sir.
Fine.
Not yet studied anyway.
Right. And you said about the HbA1c levels that may be normal or nearly normal, not that much high. Then can you tell me a cutoff?
No, sir. Actually, as I told,
as per the data or any literature, that how much HbA1c will be seen maximum. For example, if I were to say, I'm not able to exactly tell you, but what will be the cutoff
sir,
of HbA1c?
according to the NGSP, for whatever data we have on fulminant type 1 diabetes, they have described 8.7, sir.
That is what?
8.7 is what they have described for this one.
Fine. You have covered all the things. I don't have especially any question to be asked.
So in this case, LSCS was done or normal delivery was done?
Normal vaginal delivery, sir.
Normal delivery. So what do you think, what may be the trigger factor for this case? Whether
Sir,
viral infection or any other trigger factor?
Sir, again, as I told, I don't have a factor establishing the viral infection in this patient.
So whether flu-like symptoms was present at that time?
Yes, sir.
Yes.
Not exactly flu-like symptoms. She had some GI symptoms like loose stools, abdominal pain, and vomiting. So actually, in the prodrome, they are describing either flu-like symptoms or some gastrointestinal symptoms. So my patient had gastrointestinal symptoms, sir.
Whether CT abdomen was done immediately or after 2 to 3 days?
No, sir. CCT actually not even
because
after 2 to 3 days.
If CT is done immediately, then
there is no
the
role.
finding may be normal.
Sir, initially, actually after we got the USG only done initially, but again, since we could not find any conclusion, after stabilizing her DK only we got CCT done actually for ruling out pancreatitis, and that did not give any evidence.
Okay, so this is a unique case. Okay.
So have you followed the amylase and lipase level?
Yes, sir. We before discharge also we had sent the levels. By that time it had come down to normal.
So what is your criteria to treat the patient? Meaning by how you manage this patient? Because HbA1c level is below 8% in this case. So what is your criteria level to give insulin? How much insulin will you give? For what purpose? What was the criteria to set these patients to how much insulin should be given to this patient?
Sir, actually in this patient, after the resolution of her DK, we put her on the basal bolus regimen. So initially she required some higher range. As far as I remember, she required around 16 units or so. Then gradually, according to her glycemic control was achieved. She was with us for almost 1 month, sir. This patient was with us for almost 1 month. Initially she had a long ICU stay also. After that, before the discharge, we saw almost for 1 week that she attained good glycemic control of 120 to 180. With a basal bolus regimen of 12 units 3 times a day and glargine 14 units. So based on that only we have discharged her. We asked her for follow-up also, and she was having good glycemic control.
Have you understood my question? My question was that कि इसको जो है ना किस लेवल पे मतलब किसको कितना इंसुलिन देंगे वो हम लोग कैसे डिसाइड करेंगे?
सर वो डिसाइड करने मींस पेशेंट का
requirement of insulin therapy.
हाँ.
Sir is asking
Okay.
requirement of insulin therapy. How will you decide how much insulin you have to give to the patient?
Sir, initially post the DK, we will take.
Generally, we take the HbA1c level and fasting blood sugar. So fasting blood sugar may be sometimes lower depending on the diet plan. So how do you fix the insulin level?
Fixing the insulin level. Sir, initially post DK, like any normal patient, how we will bring them on the sugar control with insulin.
Those patients we can take care of the HbA1c
level also. But in this patient, sir, like
that was before.
no, sir. We based on her random blood sugar levels only, we discharged on her random blood sugar levels only, not HbA1c levels.
Antibodies were negative?
Yeah, antibodies were negative.
Then why do we call it type 1 diabetes?
Sir, it is a subtype of.
So why do we call it is a subtype of type 1?
Sir, why? Because in type 1 diabetes mellitus also there is destruction of beta cells. In this there is.
This was the original case, or it
Yes,
is a
sir.
fabricated?
No,
I'm
no,
just
no.
asking.
No, this is a case that presented to us in emergency. She was with us in our ICU for almost 1 month. She was in our ward also. As I told, almost 1 month duration she was with us, sir, this
Good.
patient.
Thank you. Appreciate the interns as well, because again I'm telling, as an intern I never presented a poster or presentation in anywhere, any conference. So all the certificates are with Dr. Pushparaj, or maybe you can ask him regarding that. And the best, or the first or the second, that certificates I think will be given in the valedictory part of the conference that will be taken place at the last of the conference. Thank you. Boss,
No, all presentation are good, or rather best, in your part and our part also. And really the participation makes a lot to any events. So you participated well, presented well. So huge applause to you all, and thanks for your participation. Everyone will get participation certificate and some numbers, that 1, 2, 3. It is rarely a number, and participation is the main thing. Okay.
thank you. It's mainly about teaching. You teaching us, we teaching you. It's so we really appreciate. And you be here till 6. That is also appreciating. So let's see, and let's move to the hall. हाँ सर, ठीक है. Thank you.